Good morning, everyone. Myself, Dr. Lavanya, Senior Hematology Department. Firstly, I would like to thank the expert for taking their precious time out and making to the. Now we are moving on to the session number 7. I would like to invite the chairpersons for this session. Dr. Parniti Gutha, ma'am, Pediatric Hemato-Oncologist in American Oncology Institute, Hyderabad. Dr. Dharma Chowdhury, sir, Director of Hematology and Bone Marrow Transplant at Sanar Hospital. Over to you, sir.
So, good morning all, and thank you Ganesh and team and Kayur. So, without wasting time, we'll move to the session, and the first speaker will be Dr. Prantar Chakravarti, and he will be speaking on AI in hematology. Dr. Prantar is consultant at Johor Corporation. Over to Dr. Prantar.
Thank you. Yeah. Good morning, that too on a Sunday. I know how painful it is to come out of your home and your comfort zone. So, today in the next 12 to 13 minutes, I will be looking at artificial intelligence and try to see whether it is even capable of fighting with natural intelligence and what it can do in hematology. So, greetings from Govindaperi village. This is our community kitchen and this. Now, does anyone know this lady? Have any one of you seen her? Well, you will not be able to see her because it has been generated by Google Bird in the morning. So, now you have large language models. I told Google that I will be speaking on AI and explaining. So, you generate an image and this image has been generated, right. So, it has no copyright. Those of you who get to journals and then they say you get a picture and all, you just now Bird or even Bing Koi or others can generate it. So, basically if you look at artificial intelligence in healthcare, you will see it is in diagnosis, then treatment prognostication, and also it is helping in drug discovery and patient management. So, I will show you some glimpses of how it has already arrived. Remember, artificial intelligence is artificial. So, it is a copy of human intelligence. It is trying to reproduce the human brain's functions being done by humans, capacity being given to machines, so that they can memorize and learn from experience. Whether we can think and create, we do not know, but it can speak, it can create videos, I showed you image, and our goal is that it can judge and make decisions. So, now you have to understand that there are a lot of terminologies. In the medical field, you do not have to bother about all of this, but if you do not know the terminologies, others may make a fool out of you. So, the entire universe is artificial intelligence, a program that can sense, reason, act and adapt. Within it, one technology is machine learning, which are basically algorithms whose performance improve as they are exposed to more data over time, and I will explain it. And a subset of that is deep learning, which has led to the large language models and others, which I will show you. So, what does AI promise us, right? It promises us to provide a composite panoramic view of individuals' medical data, provided you are capturing the data, right. It can improve decision making. It is supposed to be safer, avoid errors such as misdiagnosis, unnecessary procedures, help in the ordering and interpreting of tests, recommend optimum treatment. Now, industrial revolution has gone through certain stages. So, it started with the steam engine. Right now, we are in industrial revolution phase 4. Now, AI, and there has been a beautiful article published in January at JAMA, where they say AI also had 3 phases. The first phase, which we call of symbolic AI and probabilistic models, started in the 1950s, even when we were not born. So it followed directly encoded rules. So if, then, or tree rules, and these were based on expert knowledge, and they were hand encoded through traditional coding. So performance capability is what? It could ask a series of questions to determine, and then it could learn whether the picture is of a cat or dog. And all of you know the story of Deep Blue, which beat Kasparov in chess. In healthcare, this was the beginning of rule-based CDS, right? Clinical decision support systems. Challenges were that the person who was putting in the data, if he was not an expert or if he put in something wrong, the machine would blindly copy it, right? So that was AI 1.0. Then 2.0. This was, as I showed you, machine learning, then deep learning. This has started only in 2011, still going in. This can predict or classify information, but it's task specific. So one task at a time, and it requires new data and retraining to perform the new tasks. So what can it do other than identify a cat or dog? It can even answer how many dogs will be in the park at noon, because it has that data. It knows based on the last, say, month's data, it can tell you. You can do photo searching without manual tagging, that is what Google Photos does. Voice recognition, language translation, even natural language processing. In healthcare, this 2.0 has been used in identify diabetic retinopathy, where you know Google did a field trial with Arvind group, breast cancer, lung cancer screening from CTs, skin conditions classification, and prediction based on health records. So when a hospital says that we have now an improved EHR, it basically looks at your previous prescriptions and tries to generate something. The problem is that it can only perform under certain circumstances. Real time, it can fail, and it has a phenomena of catastrophic forgetting. Like one task it goes, it forgets about the other thing of that patient. Abdominal pain, which was also associated with vomiting, that can go away. And it cannot remember early parts of a long sequence of event. And again, the bias will obviously be there, because whatever you have trained it, it will do that. And then became the so-called golden era of AI, which you know as ChatGPT, AI 3.0 foundational models. This is capable of generating new content, text, sound, images, different types of tasks without new data. So once you train it, it goes on improving itself. Self-supervised learning, I'll explain what is supervised and not supervised learning. Now it can tell, if you ask it, that it can not only differentiate between a cat and a dog, but it can tell you what is the difference between a cat and a dog. And what are we doing in healthcare? So you know about Google's MatePalm, Palm 2. These are medically tuned large language models. You have PubMed GPT, BioGPT. So Palm 2 has already cleared USMLE, NEET. It only shows that we can't frame proper questions. But one of the greatest problems here is, there in version 2 it was catastrophic forgetting. Here it is hallucination. It can generate a review article even giving references, none of them exist. Because remember, when you are saying that is a cat afraid of a dog, or what is the relationship between a cat and a dog, it will tell you cat is afraid of a dog, but it doesn't have our brain. It is statistics on steroids. So it knows when this word is there, each word has its own, GPS you can call it, and dog, then the common words which are used in between is this. So remember, it can't think, but it can show as if it is thinking. So this is what deep learning does. We are trying to copy the human brain, and we are trying to do something. So here what you have to do basically is data collection and pre-processing. So if you are not collecting data in your clinics, then you cannot even have natural intelligence as well as artificial. Artificial intelligence needs more data. You select a particular model, you train that model, and then you have to do hyperparameter tuning so that there is no confabulation, no hallucination. So there was this beautiful review article in BJH during COVID. So supervised learning means you label the data and then it predicts it. Unsupervised it can see something which you cannot see. And then these learning models, KNN, support vector machine, random forest, don't worry about this, but you should have a basic idea as to which works well there. And those of us who came into medicine because we were not good in mathematics, it's all mathematics only, right? And this is how the technology has developed. In 2016 only, in terms of voice recognition and words, pictures, computers are better than us. And this is how the LLMs have developed. So there are a number of LLMs, don't worry, I'll share this presentation. GPT-4 is now there. 10 to 100 trillion parameters are there in a human. These are black boxes. We know that they have reached till around 3 trillion. So it can do all these things, including sentiment analysis. But remember, ChatGPT performs like a 9-year-old child in the theory of mind test. So mind is not there, right? So in any scenario, including hematology, you look at the data, you can use it for prediction and screening, you can use it for diagnosis and then treatment and even policy making. And the big data is generated from genomics, epigenetics, proteomics, transcriptomics and electronic hospital records. So genomics has gone so far, which gives us the data, and this is the usual cycle which we do. So now you'll ask me, how does it help in hematology? So the challenges in hematology are unique. You have to predict which person will progress. You can screen for certain diseases, especially genetic, diagnostic, risk stratification, choosing the best treatment, monitoring and follow-up. And if you look at AI, it is already working there, but if you look at other disciplines, FDA submissions, there is radiology, you can see there, cardiology, hematology is that small dot on 4, right? And these are the things which are going on. So I'll give you a scenario because there are some transplanters here, otherwise also. So if you formulate a clinical question, how can we identify AML patients at high risk of relapse following androgenic HSCT? We are all looking for answers. The available data are clinical registry, patient, donor, transplantation parameters, next generation sequencing of a targeted panel. This will be a supervised learning project. You identify properties, limitations. We wrote an inherent selection bias since only patients who undergo transplantation are included. So if they have not undergone transplant, obviously you filter out that data. You prepare the data, model it, test the model, and model's performance is evaluated both on the original data and then a test data set, not previously included in training. So what they did was, they did a C index training set and it came at 0.71, testing also 0.66. So it was well calibrated, it was working, and then it was deployed, right? So in the last minute, I'll tell you that there are some very good review articles. You can go through them. It is basically pattern recognition, image segmentation. There are these point of care devices. So those who are from the lab side, you are at A, peripheral blood film, light microscopy review, report generation, lab information. This is what AI is doing to your lab information system. Data from everywhere, triage the cases, reject poor quality, everything is there, get the clinical data, provide report and the diagnosis. So all are doing it, and along with Indian Statistical Institute, we have recently published our effort of pathologist-like explanations. You know, there are so many models which are black boxes, which never tell you what they do. No one knows how ChatGPT works, right? So here we have used it as the pathologists do. It looks at the size. Yeah, this will be my last slide, don't worry. So it looks at the slide, it looks size, relative cells, granularity, and tries to report like a pathologist. This is there in bioRxiv, and we will be presenting it in Athens later this year at the Microsoft CMT. So these are some of the opportunities. Whether you are a clinician, whether you are in the lab, you are the starting point, and do not give the space to so-called engineers and data scientists, then you will never know what you are using, because ultimately you will be signing the discharge summary and you will be signing the lab reports. Thank you very much.
Thank you, Dr. Prantha, for your excellent overview on AI in Hemat. So can we have one or two questions? Dr. Revati, please.
Yeah.
If we are using all these systems, where do we stand with the medico-legal system?
Yeah. So that is what I told you. As far as World Health Organization has just published some ethics guidelines, medico-legally none of these systems can independently generate anything. So they are looked as a complementary tool to us in the clinics, in the lab. Ultimately it's a human who will sign it. So that is the situation today. So that's why I always tell, if you're using, around 350 AI tools have been approved by US FDA. Some of them are black boxes. So if you do not know how it does it, there is a risk there. You should talk to the developers, the manufacturers, and you should validate it in your setting. I know of a famous hospital group in India who brought in IBM Watson and advertised that cancer diagnosis is not a problem. It was a crores of rupees project. It failed. It didn't work. I know your hospital group is also using something, but that is AI 2.0 of predicting prescriptions. But remember, you are the team leader. If you have the legal responsibility, then you should know what is going on. And that's why you should understand at least the basics of how they operate and how the biases are there. Thank you. Yes. Yeah, Uday. Yeah.
Now, AI is a very powerful thing, but even the calculators that we use,
Yes.
the medical calculators that we use, they are basically created on 10 patients, 15 patients. So don't you think our country, we should come up with some QC guidelines for the various AIs which are being introduced to the medical fraternity from time to time?
Absolutely. And I do not call it quality assurance also. I call it continuous validation, right? So if you'll be amazed to know that some of the instruments even which we use today have been validated only on 30 samples. NGS, it's another black box. Everybody says, there's a point of care for thalassemia diagnosis, it is using AI. I ask them what kind of AI and how does it modify it? What is the training data? If people are not able to share that, it's very risky to use it. Like in drugs also, you say, you show me the DMD file. What was the raw material? Where did you keep it? If you're not showing me what you're doing, I am paying for it, and then I might be sued for it. So I think the AI engineering team and all, they are concerned about safety of the human race. But in healthcare, we should have our own governing body. So there is a government task force on AI in healthcare. They are having some meetings, I think twice a month, once in 2 months. I have already requested them that they should come out with guidelines as to how a user will evaluate a particular system, because it's a machine after all. So yeah, I don't know when it will happen, but we are thinking that it should happen.
Thank you, sir.
Thank you.
If there are no further questions, we'll move on to the next talk. I would like to invite Dr. Revati Raj, Senior Pediatric Hematology Consultant and Pediatric BMT Physician at Apollo Hospitals, Chennai, to give a talk on Pediatric ALL.
Can you hear me? Yeah. So I have 12 minutes to talk about ALL in children. So I'm going to be very quick. All of you know that ALL is a story of success, and over decades things have improved. So how did it happen? It is a story of eternal hope. And what I'm going to divide this talk into 3 phases: what we have learned from yesterday, what are we doing today and what is the hope for tomorrow. And yesterday we saw this Emily Whitehead story in SACT conference, and it was amazing how we have CAR T cells for high-risk ALL children in India. So the thing is divided into 4 parts: how we beat cancer, or how we try to beat cancer, as Dr. Prantar said, is by risk stratification, providing optimal treatment, supportive care, working together, and how to think about a child who's having treatment today to prevent side effects in the future. So the first part is risk stratification based therapy. This I'm going to talk about what we did in the past and how we did the NCI based risk stratification based on their initial presentation. Then we learned that cytogenetics was important, and then we segregated them into standard risk and high risk children based on cytogenetics. We learned that measurable residual disease is important, and through flow risk stratified, and those who were standard risk or intermediate risk went on to high risk protocols if they were MRD positive. Then we have also got better over the last decades on how to prevent side effects of the chemotherapy. And one of the biggest difference in my lifetime was with the pegylated asparaginase, where you had prolonged and sustained depletion of asparagine, and that translated into better survival. Rasburicase, I think initially we used to do hemodialysis for children with high white count, but now we are able to prevent dialysis for tumor lysis. So all of these supportive care, access to blood products, are educating our nurses, fighting drug-resistant antibiotics. All of these have been the challenges in the 1990s and in the 2000s for having better outcomes in ALL. The last phase was venous access, because for these children who came regularly, it was a big problem, and even that we have better facilities with PICC lines, chemopods, and also we've learned that the maintenance phase of ALL is important. Induction is important, consolidation is important, reinduction is important, and the maintenance, how to titrate. And with this, as Prantar said about using not artificial intelligence, but even basic WhatsApp to keep track of maintenance chemotherapy for our patients. The biggest difference we saw was in the pH positive ALL, where we added the tyrosine kinase inhibitors to the chemotherapy backbone, and things got better for pediatric ALL. So the third aspect of what we learned over the last few decades is how to work together. Some of us followed children's oncology group, some of them BFM, and some of them UK MRC, depending on where we trained initially. But you now see that all the big groups have a similar protocol. They're not so different as it was in the 1990s or in the 2000s. They all have the same backbone. So the Western protocols are now merged together into one trial called All Together. So which is the way forward so that we can learn from each other. How do we prevent late side effects? Again, this was the best learning over the last 2 decades, that the CNS is a sanctuary site, but we don't need to use high-dose methotrexate for all children. We don't need to use 5 grams per meter square. We can get away with 2 grams per meter square. All this is to reduce regimen-related toxicity and definitely not have late side effects like hormone insufficiency, growth retardation, and prevent cranial radiotherapy, and definitely not use cranial radiotherapy for prophylaxis. So this is a review of our center data that we had looked at, and out of the children whom we put on regimen A and regimen B, we used the UK MRC protocol, and on the 287 patients, our median diagnosis was 6 years, and based on cytogenetics, we did a risk stratification and did the induction with 4 drugs for the high-risk children and 3 drugs for the standard-risk children. Based on the MRD status, 74 children moved to the higher-risk schedule because they were MRD positive or they had hypodiploid or one of the high-risk cytogenetics. And this is what we saw, that with supportive care, we have to be careful, and some of the supportive care we added were to give zinc, vitamin A, D supplements. This is all for our country. And maintenance, we were very rigid about keeping 2,500 to 3,500 because most of the labs in smaller centers, we couldn't look at ANC. So the regimen escalation, despite all of this, we had a relapse of about 20%, and most of them for us occurred in in all of the category, but what we thought was standard risk. So basically our MRD and our risk stratification needed to get better, so we have to do better. So relapse, most of our relapses happened when they went on to maintenance, so that means we can do better with the risk stratification. So what do we do today? Our risk stratification has changed based on the experience over the last 2 decades. We no longer call ALL as ALL, we call them precursor lymphoid neoplasms, and basically our first best step was to extend our same protocol to the teenage young adults, and up to 25 use the same protocol. We now have a category called PH-like ALL. So some of the kids who behave like the Philadelphia chromosome, and we can augment their chemotherapy upfront so that they don't relapse. We are integrating next generation sequencing into our protocol, so that especially for the T-ALL, because on the day one, if we know that they are notch, we don't worry about them, but if they have RAS or PTEN, these are the high-risk children who are at higher risk of relapse, and selectively use NGS, not for everyone, but for selected patients. And we have optimized the chemotherapy and supportive care. A very small step, 6-MP is now available as a liquid formulation. It used to be a pain to divide the drug into quarter tablet, half tablet, 3 days a week. So that's made a big difference, and also based on the thiopurine methyltransferase levels, we can optimize the one drug that is so important. New drugs in the high-risk T-ALL, upfront adding nelarabine improved survival, which we saw from data in the COG trials, and also blinatumomab upfront in infants. So this is what we are using before they go on to the MARMA protocol. After induction, add 1 cycle of blinatumomab, because these are the high-risk children who are going to relapse. So how to prevent late side effects? Again, reducing the dose of methotrexate. Not everyone needs the 5 grams per meter square, but also Capizzi is as good as high-dose methotrexate in T-ALL, which can be given as outpatients. What are we doing about learning, working together in our country? The amazing thing about ICICL, which is the protocol for children in India, is that we've standardized MRD across the country through ICICL and taught everyone how important maintenance is. So this is definitely going to be a change for the future. What I anticipate will be for the future is that we'll understand better through efforts of several groups how to use NGS, because there's so much data available. We really don't know who is actually high risk, or we don't have to overtreat some children just because an NGS result said that they are on high risk. So this is some data we're trying to still analyze. Maybe, as the adults have said, we will have chemotherapy-free regimens. We don't know. We are definitely transplanting less children for ALL these days because of the drugs available, because if you're using targeted drugs, if you're using newer agents like blinatumomab, the number of children whom we would offer transplant is lower, and upfront ALL transplants have just definitely come down. And whether we incorporate CAR T cells in the algorithm for the high-risk children, that is to be seen, and that's what people are doing in the West. And I think this is one of the amazing differences that we have seen. I didn't talk much about the reinduction. We used to lose a lot of children to reinduction, and we found that anthracyclines at reinduction caused a lot of problems. So our own study, fludarabine, we use with bortezomib and cytarabine rather than anthracycline idarubicin, and with that we've had effective salvages rather than lose them to reinduction. CAR T cells, teaching the immune system how to fight cancers, and I think that would make a difference, but here we have to use it with caution, because once the child is better and they are in remission from ALL, we have to look at the lifelong B-cell aplasia and how to support them. So this is our disease-free survival when we did the analysis till 2019, and this is St. Jude's. So they are at 94% disease-free survival. So somehow we have to move our map from the overall 79%, 80% to 94%, and this can be done only as a team approach. So my message would be that when we know better, then we should do better, and we are waiting for data to learn from each other to see how things can be done for a better future for our children. The most important thing is to never stop trying for them, and anything I do here is not an individual effort. So I'm very grateful to all the patient families and my team, our nurses who made this possible, and every little dot counts. What is our flow cytometry person saying? Lab, microbiology, cultures, nursing, how do they handle central lines? A lot of you will be treating childhood ALL, so from day one, what you need to know is how to be a team player, because if you say, here I am, listen to what I say, that's not what's going to work, but we have to know how to connect all the dots to make things work for our children with ALL. Thank you. It's a bit scary to have such a big image of yourself on stage. Yeah. I'm sorry I breezed through. I thought 12 minutes was too less, so I had to finish fast.
So if I may ask, yeah, Dr. Revati, post-MRD, post-induction MRD positive, what are you doing currently?
So if they are MRD positive, we did do the augmented BFM consolidation and then make our decision after consolidation. So if they are MRD negative after consolidation, they continue on regimen C, the high-risk regimen. If they are MRD positive, then we do further analysis, the NGS-based risk stratification and everything to find out why they are high risk, offer blinatumomab or FLA-B, depending on their financial background, and if they are negative, start talking to them about upfront transplant. If they are MRD positive after consolidation. So even in pH positive ALL, the decision to transplant or not is all based on the MRD after consolidation. The part I didn't touch was about ETP ALL, because we no longer consider them high risk. Even if they are MRD positive for a long time, give them an even longer rope, even after consolidation, to clear the MRD. So ETP ALL is an exception. So even if they are MRD positive after consolidation, we don't jump in and say you need a transplant.
I just continuing same on the MRD stuff. Supposing you got a high risk child and he's MRD negative at end of induction, would you just say, okay, that's it? Or would you keep on doing an MRD maybe at a 3 or a 6 monthly interval?
No, yeah. So this is where it's a good question. This is where our practice has changed. If they are MRD negative at the end of induction, then we don't repeat the MRD unless there are some cytopenias or something is worrying you. Because in these children, when we go bang, bang, bang with chemotherapy, always they get hematogones coming up. And when we try and do MRD at time points where we don't know how to interpret, then it comes MRD positive, because most labs are looking at hematogones. And then the family is worried, we are worried. That is if you trust your day 28 MRD.
The same lab would have done the day 28 MRD, which probably would do after consolidation?
Yeah, so stick to one lab and follow up in the same lab, yeah. So that is why the whole principle of icicle standardization of MRD, it made a big difference. And if you had problems and if you have concerns, you can send it to the reference lab in Tata. So this is another thing, always store the DNA at diagnosis and day 28, because if you want to go back and look at your data, if you have the DNA stored, and nowadays we have access to RNA storage also, so we store routinely for 20 years, we have DNA RNA stored at day 0 and day 28. Now we are doing RNA extraction and storage also.
Excellent talk, Dr. Revati, as usual. Connect all the dots, and teamwork has made a big difference to our children. Thank you very much.
Moving to the next talk, I invite Dr. Sarath Damodar to speak on graft versus host disease. And we know Dr. Sarath, he is Chief of Hematology and Transplant Services at Majmudas Shaw Medical Center in Naran Hridayalaya Hospital, Bangalore. Sarath.
Okay, yeah. So good morning, everybody. We're jumping into a transplant topic straight away now. So Ganesh has given me this, this great task of doing GVHD in 12 minutes is what he specified. So first of all, congratulations to him. He's the new star there among the other stars there at this inauguration, which we got some glimpses of, and his new BMT unit, which has come up, which is apparently state of the art and something which we all need to see. So quickly over the next 10-12 minutes, we'll just quickly run through the aspects of GVH. So essentially acute and chronic. I won't go too much into chronic for want of time, but just putting things in perspective. We're still far away from European and American numbers from a transplant perspective. I think we have improved, but a long way to go. And then the eternal cutoff of day 100, which was used to separate acute and chronic GVHD, is kind of no more in existence. You've got the late onset, you've got recurrent GVH, persistent GVHD, where acute GVHD overlaps and crosses on to chronic GVHD. So there's a lot of overlap, and thereby when you kind of recommend some medication for one set of, a subset of GVH, it's a little difficult to kind of pinpoint and say that's what will work best. There will be a little bit of overlap, which we need to certainly consider. Now, essentially, the pathophysiology is initially the damage which occurs during conditioning. You've got pathogen-associated and damage-associated molecular patterns there, which then trigger off, host antigen activation. Then the donor T cell comes into play. You've got cytokines getting released. So this is the basic, one picture just to demonstrate what happens in triggers of GVHD. And the three systems which are typically involved is gut, liver, and skin. This is for the students in the audience. So clearly we've got down to staging, and now we have the magic criteria, which is clearly well defined as to what are the criteria there. The add-on from the previous thing has been the upper GI symptoms also, which are included there. And clearly there's relevance to that because, in the past we used to never really chase that, but clearly nowadays you do, even to the extent of having to scope on sometimes. And based on which we risk stratify. Clearly the grade 1 is not something we would worry about. When you look at data, everybody's talking about the numbers of percentages of grade 2 to 4, which is the troublesome GVH, which is kind of the area where you need to intervene. So just a kind of algorithm on how we would manage. So if you have only skin and you do not have gut and liver, then initially only topical steroids is which would get used. But subsequently, if you're anything beyond, you've got gut, liver involvement, then typically steroids is the first thing to go, and standard dose of 2 milligrams per kg. Subsequent to that, ruxolitinib has come in as the second line now. Clearly there's enough of data there, and I think our own usage within our own subset of people have experience, and that seems to be the way forward. And then you've got a big list of drugs for possible third line. People have their choices there on what they bring on, and this is just a list of all those third line choices which you have. There's a big list of them. And some of the ones which are actually used in our country is what I've just kind of ticked off there. Some of us have done this basiliximab, etanercept combinations. We've got some reasonable response. In the past, we used to use ATG. There's ECP, which is now a little more easily available. There has been some data on fecal microbiota transplants. MSC, some of us have used to some, with some responses in some extent. MTX is the standard one, which is anyways there in part of your protocol, including MMF. And sirolimus is an mTOR inhibitor, which some of us also have started using. So you have a big list of drugs, and each one, it depends on what you are comfortable with, what you've used at your center, and what is the data which you produce at your own center for you to get a little comfort on recommending that for your patients. Clearly, the point I wanted to highlight here is that ECP is now becoming more and more available for our set of patients, and I think there's some good data which is coming out of that. This I particularly put up specifically for the benefit of postgraduates. There's a nice consensus from the EBMT, this is Lancet 2020, on the prophylaxis and management, clear guidelines, what is the evidence for it, what is the level of recommendation, and this is good to know. It's also good to reinforce and tell us that what we've been doing has got some basis for it and evidence for it. So you can see a lot of the level 1 evidence here and approval of 100%, which is your standard GVHD prophylaxis of a calcineurin inhibitor with an anti-metabolite. You could either be doing TAC or cyclosporin, and MTX is what we used. In the non-myeloablative and the RIG settings, you will also bring in MMF, and it depends on what you're comfortable with. So ATG again is something, the rabbit ATG or grapholon is something which again has come up with level evidence between 1 and 2B, especially in the both in the match related setting and in the unrelated donor setting. Now standard guidelines on what is the dosing, what are the levels you're supposed to do, how would you monitor, and and your taper off schedule is also kind of clearly described, and this is a nice little consensus which they've come together. And on your tapering schedule and your monitoring and the dosing at which all these 3 drugs are actually recommended is also there. And I'm not really running through this quickly because this is all kind of data which is there basically as guidelines, and there's enough evidence to actually recommend this in our treatment schedules. Now the steroid, once you get GVH, clearly there is that guideline to start at 2 mg per kg of steroid, and then you try and start a taper protocol after about 7 days, which is when you begin to start defining this business of steroid refractory or unresponsiveness, when you start thinking in terms of a second line. And at this point in time, when they finished that recommendation of steroid, the second line they put down that there was no standard guideline at that point in time, but clearly with more data coming on drugs, that's come up as the second line agent. But the third line again is a big maze of a lot of drugs which you can potentially use, which are all listed there. Now, just a little thought process: when you get GVHD, just remember that everything post-transplant is not always GVH. You can have a lot of other mimics of GVHD, which can be right from the mucositis. This is a very busy slide. I don't expect you all to read it, but I'll just tell you the gist of it. So just the tissue damage in mucositis itself can mimic it. You can have infections, you can have malabsorption, all of that presenting, and thereby you need to be careful that you consider all of that before you label somebody as steroid unresponsiveness or steroid dependent and start intensifying your immunosuppression. So this is something which we need to parallelly look at so that you don't miss the bigger picture there when you're talking about GVH. Now this is a little multi-centered US data which I just put together just to look at about 500 odd patients. What is the actual real world setting there, and then to see how it kind of fits into our setting on patients, this is typically all adult patients in that time frame of about 3 years, on what was the incidence they had, the incidence of grade 2 to 4 GVHD, how many of them needed additional treatment beyond steroids, and how many of them were actually steroid unresponsive, and then what was the mortality related to that, because that's something which is a worry. Once you have somebody who's steroid refractory and you're going on intensifying the immunosuppression, clearly it will come back to haunt you because their infection rates take off, and in our country that's a pretty big issue to discuss. So this was the data which is actually collated, and this was the breakup of that demographic data of about close to 500 odd patients. All of them were predominantly a white population, 65% in CR, and you can see the GVHD prophylaxis is what I kind of already have mentioned. So standard recommendations there. They were using more of TAC in about 50 odd % of patients. There was also MMF in about 40 odd % of patients there. So a little more usage of TAC compared to cyclosporin in this subset of patients. And again, PBSC as your graft source and matched unrelated about 45% in this particular subset of patients put together. Now this is just a graph to show you that once you get one level of GVH, it generally tends to stay there. It's not much movement. See, once you're starting at grade 4, at diagnosis and then max grade, you're kind of sitting there. So this is your most troublesome subset when you hit 4. Generally, difficult to kind of pull out. 3 again tends to stay like that or sometimes progress to 4. It's rarer for 1 and 2 to quickly jump to this. Very small subset of patients. Some of them might progress to a slightly higher grade, but then you may be able to bring things under control here. But generally when you're at 3 and 4, you're in trouble, because it tends to stay like that or generally worsens. A few of the 3s you're able to pull out, and that's just to show you on real world what actually happens, and this is what exactly translates into mortality. So you look at median survival here, when you're only 1 or 2 and progressed, you're still doing very well, but the moment you're 3 or 4 and you're progressing, your survival typically dramatically drops, and this is what all of us know. So clearly preventive strategies have to be extremely important here, because once you got to a 3 or 4, you know you're in big trouble, clearly translating into higher mortality and lesser survival. And this was the gist of whatever that study came out with. 40% of patients with acute GVHD experienced disease progression and developed severe grade 3-4 in spite of systemic treatment, first line. And then if you looked at their survival, 1 year overall mortality from date of acute GVHD and diagnosis in NRM was 35% and 26% respectively. So you know that there's a significant contribution to mortality when you get GVHD which is not responsive to your standard initial treatment. Next slide is on the FDA approvals. Like I did mention that from 2020 things have progressed. We've got 2 of these drugs which are approved now. One is for acute GVHD at this dosing, and ibrutinib for chronic GVHD. Rux can also be used in the chronic GVHD setting also at that particular dose. And both these drugs are now available for us, and that's something which is making life a little easier for us, and clearly all of us have experience in using this. Risk factors, typically this is what has been described, obviously the degree of HLA mismatch, female to male transplant, use of TBI at least for acute GVHD, and the PBSC graft for chronic GVHD. There's reasonable data for that, and some of our own Indian data also shows the same thing. Now chronic GVHD, I did mention that we still have 2 of these drugs, ibrutinib and Rux here. Both of them have shown reasonably good response rates, as high as 60 to 70%, and the Rux data for acute GVHD again is somewhere in that range. Now in the steroid refractory setting, the guidelines have put this all together. Like I did mention, Rux has come up as your second line. There's a big list of other drugs, and recently you've got ibrutinib, which has also got approval for chronic GVH. Some data, I will not really go through too much of detail. This is the published data which is actually supporting whatever I've told you on numbers, and clearly just to highlight this particular thing on the results with ECP, which is kind of looking quite impressive when you look at this data, looking at the CR rates both in grade 2 and grade 3 GVH, and the Rux data which is showing response rates about 50 to 60%. We all have done this usage of basiliximab and etanercept and some of the MSCs. Not so great data there. CR rates of about 70% described here in this particular study, but I don't think that's panned out in some of our own usage. And again with MSCs, the response rates don't look that great. So if you just had to put an algorithm here, this is the gist of it. Steroid refractory GVHD, you've got your front line after steroid, then you've got a lot of other things which you can use here. In chronic GVHD, you've got both Rux and ibrutinib which is available, and then you can go on to ECB and a host of other things which you can do in your various treatment algorithms. But this is just one slide to just put everything into perspective and tell you how to approach this. Now this is some of our own data which we dug out some time back on what was our GVHD patterns. This was close to about 600 odd patients, and there was a reasonable subset of matched sibling, haplo and MUD, and you can see that we are hitting about 30% in the matched sibling and the haplos, and definitely higher in the MUDs, to overall to come to about 36%, but clearly there's a little skewing there looking at the MUD transplants compared to the matched sibling and the haplo. And in our own experience, I think the haplos seem to be doing a little better than our MUDs. Now this is a little presentation at the last year's APBMT on steroid refractory graft versus host disease, and its poor prognosis when you're steroid refractory. So this is about 205 adult patients between this time period of 2015 to 2020, and the standard definition of steroid refractory GVH. In this subset, out of these 205, 72, that is 35%, developed grade 2 to 4, which is what was in keeping with the other data. And in this, about half of them was steroid responsive and the other half was steroid refractory. And clearly, when you're steroid responsive, you could pull out about 80-90% of them responded, whereas in the other subset, your survival clearly dropped to as low as 20% in the subset which was steroid refractory in spite of all the treatment. So clearly, this is trouble for us. So I think that should be my last slide. I'll end. Yeah. So this is our first patient who's undergone a transplant for thal 20 years ago, and thankfully didn't develop GVH, and that's why he's looking so good. Thank you.
Thank you, Dr. Sarath, for your excellent overview. So open for any questions from the audience. If there's no question, then we'll move to next talk.
Yes.
I would like to invite Dr. Sunil Bhatt, Vice Chairman, Oncology Services, Director and Clinical Lead, Pediatric Hematology Oncology at Narayana Health, Bangalore, to give a talk on pediatric transplant.
Very good morning, and thank you, Dr. Ganesh, for having us all here. It's a rapid fire, actually. So to cover pediatric transplants in 12-13 minutes is extremely impossible. Dr. Revati had a lot of sympathies with me in the morning. How am I going to do that? But anyway, so I think we'll focus on, I'll start a case presentation first. And this was a 16, 17-month-old baby who presented with multiple swellings on his body, abdominal distension for a few months, and from a secondary consanguineous marriage. There was an interesting history that the two siblings to this family earlier on had succumbed to BCG lymphadenitis, and after BCG vaccination had died at 6 months of age. Fortunately, this child was not vaccinated for this, and this is his presentation when he came to us. He was pale, he had very typical rash, failure to thrive, and gross megaly at presentation. Routine evaluations, what we do, were all negative. We ended up doing lymph node and liver biopsies. They didn't show anything. But with the typical history in the family, with two deaths due to BCG vaccine, we looked at immunodeficiencies. T and B subsets were normal in number, immunoglobulins are normal in number. But what was very interesting with this kid was that his T lymphocytes were not proliferating to stimulus. When we do a T cell proliferation test for this kid, there was no proliferation, and this was done at 2 different time points, and the diagnosis of T cell functional defect was made. So there was no sibling who could donate. There was no unrelated donor. We didn't know the inheritors of this disease at that point of time, just many, many years ago. We didn't have access to next-gen sequencing at that point of time. So to be on the safer side, as most of them are autosomal recessive or X-linked, we took father as a donor, and he underwent transplant with his father. This is the same kid now, a month post-transplantation. His lymph nodes have resolved, organ is resolved, his rash is resolved, and looks like a healthy baby now. He's now 8-9 months post-transplant, cured of his disease. And when he was this is this DNA which was stored before the transplantation, and then later on we could work it up, and there was a interferon gamma 2 receptor mutation in this kid, and that was probably the reason for this kid and probably the earlier 2 kids having this immunodeficiency, which was leading to T cell insufficiency. Now, while this kid was being worked up and treated, mother was 16 weeks pregnant. We couldn't offer antenatal testing because there was no mutation known at that point of time. They chose to continue the pregnancy, and the 4th baby was also born with the same condition. We could test it earlier on in that baby also had a transplant with same father's stem cells and also cured. So this is just a case to highlight that some of these illnesses in children can be even more devastating than the malignancies, and can ruin not only the children but also the families they belong to. So a lot of effort this family put in for many, many years together to have these 2 healthy children at the end of the struggle they had for many, many years. So I take a lot of pride in, a lot of contribution pediatrics has given to the transplant world. The first transplant ever done was on a child with acute myeloid leukemia, which was done by Donald Thomas from identical twin, and that led to the Nobel Prize winning later on. And the first non-malignant transplant was also done on a pediatric patient in 1968 for X-linked immunodeficiency by the gentleman here, which is called as Robert Good and considered as father of modern immunology. And the first cord blood transplant was also done on a pediatric patient, and that was by this lady called Gluckman from France. This was a kid born in US with phencylanemia. That time cord blood transplant was not FDA approved. So this kid was flown in from US to France to have cord blood transplantation, and is also cured. And this kid now is almost in his late 50s and cured of his phencylanemia. So what are the indications of transplant in children? Autologous transplant, we all know lymphomas and Hodgkin's and non-Hodgkin's are kind of standard indications, both adults and children. But we do see some of the other indications in children which are a little unique. For example, neuroblastoma stage 4 high-risk neuroblastomas. We do treat some of the brain tumors with high-risk with high-dose chemotherapy and autologous transplants like medulloblastomas and infant or the tumors in less than 3 years of age, and some other malignancies which can be used. Now, going on to the allogenic transplantation, where you use healthy donor cells, we again have malignant conditions which are, of course, again similar to adults, but there are a lot of non-malignant conditions which are unique to children, and that's where a lot of indications for children come in, and some of them are immunodeficiencies, hematopathies, bone marrow failure syndromes, and we're going to be discussing a little bit more about this in the next few slides. And of course, it can be acquired like aplastic anemia PNH, which is again common indications as we see in adults. We learned about this yesterday. Transplant works as, in autologous transplant, it works as a high dose response curve. It works as immunotherapy. But in the pediatric conditions which are non-malignant, the genetic conditions which we showed in the previous slide, it's actually a gene therapy. So it's a allogenic gene therapy. That means you're taking stem cells from a healthy donor who has a normal gene for that particular disease, and they're replacing this bone marrow by this healthy donor stem cells having the healthy gene. So it's kind of gene therapy for some of these conditions which are genetic in origin. Now going to the first, I'm going to focus next few slides on pediatric genetic diseases, because that's what, for the short time available. We have talked about leukemias in the previous slide, previous talk, and I will not be touching much about thalassemia because that's been covered yesterday in one of the talks. So immunodeficiency disorders, we're the immunodeficiency capital of the world. There's an estimation that in India, around 100,000 to 150,000, that is 1 to 1.5 lakh children are born every year with severe immunodeficiencies. And there are many causes for that. There are almost 150 mutations which are known for immunodeficiencies. The most common ones are highlighted here. But we know one pattern, that transplant is the only curative option for these genetic conditions, at least in India, because we don't have access to gene therapy for most of them. Infantile malignant osteopetrosis, again, not a very common condition, unlike immunodeficiencies, but we see them very often, especially in the southern part of this country, and transplant is the only curative option, except for one mutation which encounters in over 5% of the patients, but almost 90% of the patients have mutations which can be again cured with transplantation. When we read textbooks, the mucopolysaccharidosis, which is a storage disorder, the treatment of choice we read is enzyme replacement therapy. But the problem is enzyme replacement therapy is two. One is not available freely and it's too expensive. There's crores of rupees every year which you have to spend on enzyme replacement therapies for, and that's to be done lifelong. The second problem is storage disorders. Enzyme replacement therapy doesn't cross the blood-brain barrier, so it doesn't have any impact. It doesn't cross the blood-brain barrier, so it doesn't have any impact on the neurodegeneration which happens eventually. So transplant can be curative, in at least help in some of the conditions. We know MPS 1, 6, and 7, and there's a lot of emerging data in MPS 2 now as well. So these are the conditions where you can actually transplant them and give them, replace the enzyme which is deficient, and help them to get better. Same thing for storage disorders. Some of the lysosomal storage disorders like Gaucher's 2 and 3, alpha melanocytosis, Niemann-Pick, BNC, asparaglucosamine. These are some of the conditions where storage disorders, your transplant will be helpful. But we have to see on the other side of this table that there is no role in some of them. For example, your Gaucher's type, neuronal type of Gaucher's disease, it doesn't really help. Same thing, for example, Niemann-Pick A, which is the neuronal type of Niemann-Pick, it doesn't really help. So we have to exactly classify, identify the right mutation and risk stratify them, and then offer a transplant if at all it's beneficial in those cases. Leukodystrophies, X-linked leukodystrophy, a common condition in males, and transplant is the only curative option, especially if done early before the neurodegeneration sets in, because once the neurodegeneration sets in, you really cannot reverse some of those progressions. So again, some of these neurodegenerative disorders on the right-hand side, it may not be helpful. So again, the right disease stratification is extremely important. Now, macrophage disorders, again, we are diagnosing more and more of them. Primary HLH, it's a relatively common problem, especially again in the southern part of India due to consanguineous marriages, congenital neutropenia, reticular dysgenesis, leukocyte defects, celiac Higashi, chronic glandular disease, Grisly syndrome, not common as such in individual capacity, but we'll take this whole group together. They're relatively common, and we do come across the children on and off, and we know the transplant is the only curative option for them. Again, bone marrow failure syndrome, Fanconi anemia, Discovered congenita, Sherman-Diamond, these are bone marrow failure syndromes, Fanconi being the commonest, and all of us come across these cases on and off, and this is the only curative option for some of these diseases to cure them. Now, what's happening in India? This is the registry data. If you see from 2012 to 2022, this is on the left-hand side is the pediatric cohort, and pediatric allogenic transplants actually have overtaken adult transplants. That's because indications are more varied, and we have a lot of these non-malignant indications which can be transplanted. Thalassemia being the major chunk here, almost 30% transplant in India are happening for thalassemia for children, and then we have got all others, you know, whether it's followed by leukemias, bone marrow failure syndromes, and the other, you know, less common ones which we discussed in the previous slides. And this is the data coming from India. This is from almost more than 100 centers. Pooled across. So what's happening in our center? So I showed some of the data with some of the genetic diseases from our place. We had about 2,000 transplants, and being a referral center, we do most of haplos and allogenic transplants. This is last year transplant activity at our center. Now going to PID, the primary immunodeficiency disorders. This is some of the data we collected 2021. It's been a little bit more cases now, so almost more than 50 now. But this was 37 cases which were collated and presented. Most of them, of course, because these are PIDs, most of them are children less than 5 years of age. And if you see this here, it's all these, you know, immunodeficiencies put together, whether it's HLH being the most common, and then followed by CGDs, LAD, and SCID, Wiskott-Aldrich syndrome, and many others. And based on the donor type, haplo being the most common donor type, because we don't have unrelated donors for most of them, and most of them do not have siblings who could donate. More than half of them actually are haplodonor transplantation, and survival at about 3.5 years follow-up was about 70 to 73%, which is quite reasonable because these kids come usually sick. They are already infected. They may have comorbidities which play a role in their outcomes. And I think these things are getting better recently because I think we identify them early and transplant them early. Now coming on to the lysosomal storage disorders, which is again a genetic disorder which I was alluding earlier on. With absence of enzyme in our country, this is probably one of the attractive treatment options for the children. This is about data from 16 to 23, about 29 kids. Majority of them are MPSs, but then some Gauchers and other genetic disorders as well, which are shown here. Again, we have substantial number of haplotransplants, and there are 16 of them, and then mixture of match-related, unrelated, and family donors. And if you see here, this cohort, about 86–87% of the patients are alive and well. And most importantly, these post-transplant evaluation, they reveal sustained increase in the liver, in the linear growth. They had regression of the organomegalies, and their development milestones have improved after transplantation. And enzyme assays, which we do post-transplant, we start at 3 months, then do it 6 months and 1 year, and then follow it annually after that. All the 20 patients who are evaluable for enzyme assays have enzyme corrections post-transplant. And as I said earlier on, this, because in the transplant there's these microglial cells and the macrophage system which makes these enzymes, they cross the blood-brain barrier, and hence there's also improvement in the neuronal aspect of it, and they do not have usually progression of neuronal degeneration after the stem cell transplant, which doesn't happen with enzyme replacement therapies. So the take-home message from today is that indications of children actually are a little different from adults. We do share indications like malignancies and aplastic anemias, which are like kind of common, but there are other indications which are mostly genetic in origin, which are a little different from adult transplants. Significant numbers are genetic, and it's kind of allogenic gene therapy which are able to offer during stem cell transplantation. Exact disease subtype important to find out, because as I said, showed you the charts, you know, some of the, in fact, in the same disease, you can have different variants where transplant may or may not help. And the typical example, Gaucher, for example, or Niemann-Pick. Conditioning is to be tailored, so conditioning is tailored not only on the aspect of disease, but also in the context of the age. For example, you know, infants do not tolerate some of the conditionings very well. For example, cyclophosphamide, busulfan is not tolerated very well in infants, so it's better to use a reduced intensity or reduced toxicity transplant conditioning for those infants. Toxicities are sometimes unique. This is my last slide. Are quite unique, and challenges are also unique. For example, MPS patients, you know, they may have deformity in the chest, they may have upper respiratory obstruction, they may be already on a BiPAP or a CPAP before transplant, and that may make it challenging during the transplant as well. And we have to also remember the donors, especially the family donors who may be sibling donors, or even the parents who are the donors for these patients, have to be worked up, because they may be silently affected by the same disease, or they may be carriers of the gene, and hence that needs to be taken into consideration before we take them for the transplantation as donors. So this is my last slide, and thank you very much for your attention. I have any questions if you have. This was really a rapid fire. Thank you.
Thank you, Dr. Sunil. Yes, Dr. Sirisha.
Excellent, Sunil. It's such a nice sprint form. The marathon topic, you have put it in a short sprint format, I should say. My question is on the case scenario, what you have mentioned in the beginning. Such a case is like where you don't have a mutation positive. How do you take the family forward for the next pregnancy? I know here most predominantly adult physicians are there.
Yeah.
But when we are offering for the antenatal diagnosis for those kind of scenarios, where SCID kind of scenarios come in a sick format, you can't transplant them, but the best way of offer what we can do for the families is antenatal counseling for the
This case which
next
I showed was
pregnancy.
many years ago. That time NGS was actually not readily available in India, and this data was then looked later on by a research lab in Bangalore, and they helped us to identify the mutation. But nowadays, I don't think there's a concern. You know, I don't remember any case recently where we had a immunodeficiency, or for that matter, any of other genetic disorders where we have failed to identify a mutation. The only problem is sometimes, is this, for example, this case also, the next pregnancy was already 16, 17 weeks. So even if you knew the mutation, it may be sometimes too late to intervene if that is the case. So in that case, you just leave it. I mean, you explain the risks and leave it to the family of what they want to do. So most of the times now we're able to identify the mutation. So even if you're not treating this index child by transplant or any other mechanism, or they are too sick for anything else, it's always advisable to take a blood sample and run it for mutation, because that will help them in the future pregnancies as well. If you still do not find anything, but then you can just explain the pros and cons, because you can't be sure of inheritance patterns if you don't know what it is. It's autosomal recessive, it's X-linked. If you do not have identified anything, then the best way is to explain them and let them take a decision on what they want to do with the future pregnancies.
Yeah, and also do mutations in parents and see
Yes,
whether.
yes.
Thank you.
Okay, if there are no further questions, we'll move on to the next topic.
Thank you.
So the next speaker is Dr. Vikas Goyal, and he's going to speak on sickle cells, what's new. Dr. Vikas is a clinical hematologist and bone marrow transplant physician at Sanjeevani Hospital, Raipur.
पॉइंटर है
So
कौन सा पॉइंटर हाँ इसमें करना है नहीं Good morning, everyone. I am very thankful to Dr. Ganesh and team for inviting me in this wonderfully organized conference. So my topic for today is sickle cell disease, what's new? So let's take a case scenario. A 25-year male who is a known case of sickle cell disease, and he presented with vaso-occlusive crisis. He already took analgesic at home but not relieved. He had similar history of this crisis every 3 to 4 months, and he's already on hydroxyurea. So now the patient asks, sir, what next? I am already taking hydroxyurea, but my pain is not getting relieved. Is there any new medication? So if this question would have been asked 7 to 8 years back, we would not have any answer. But thanks to medical advancement, we are now having L-glutamine powder, injection crizanlizumab, and voxelotor, which was approved in 2019. So just a quick definition. It is hemoglobinopathy in which because of genetic abnormality, the shape of the RBC gets distorted and it becomes sickle red blood cells. It is highly prevalent in area where I live, Chhattisgarh, MP, Chhattisgarh, Vidarbha, etc. In our area, the prevalence is as high as 30%. So the red blood cells die prematurely because of the abnormal cells. Patient develops anemia, blood flow is not very good, resulting in vaso-occlusive crisis. Many organs gets affected. Immune system gets compromised because of autosplenectomy. Patient is at risk of various infections. Pregnancy becomes high risk. It is a prothrombotic state, so leads to thrombosis, and life expectancy is between 42 to 48 years. You can see that top to bottom, almost any organ can get affected by sickle cell disease. A few years back, we had only hydroxyurea as a definitive treatment for the sickle cell, but later on we are now having crizanlizumab, voxelotor. And definitely as a curative intent, bone marrow transplant and gene therapy has come into the picture. I will not go into detail of hydroxyurea because this is older medicine, and we are all now well versed that it is very effective medicine because it has shown to result in reduction in hemolysis, modest increase in Hb concentration, significant decrease in irreversibly sickle cells, and reduction in erythrocyte endothelial adhesion. But despite availability of hydroxyurea, there was certain unmet need for the management of sickle cell disease, because in this picture you can see that there is certainly a gap of average life expectancy between normal individual and sickle cell disease individual. About 30% patients die before reaching adulthood. So there was a certain need of newer medications to effectively manage the sickle cell disease. So this new agent L-glutamine was approved in 2017 by US FDA, and it was indicated for the patient of sickle cell disease who are not doing well with the hydroxyurea. Either they are not responding or they are not tolerating hydroxyurea. Mechanism of action, though the exact mechanism is incompletely understood, but it is thought to involve to reduce the oxidative stress in the red blood cells, which results ultimately in reduced sickling, decreased adhesivity to the vasculature, and increased redox potential. This is the graph. You can see that this is a graph between placebo versus L-glutamine, and in this you can see that there is 25% reduction in cumulative number of crises while patient on glutamine as compared to placebo. So there are fewer acute pain events, 4 versus 3, fewer hospitalization, 3 versus 2, fewer days in the hospital, 11 versus 7, and fewer patients with acute chest syndrome, 23 versus 9%. So it is supplied in the packet, it is supplied in a powder form, 5 gram packet, and the recommended dose is 0.3 gram per kilogram orally twice per day. Maximum daily dose we can give 30 gram. That means in an adult patient we can give 15 gram twice daily. So this was a good drug, but there was many challenges for its use, mainly because of the side effect. This powder can generate many GI intolerance like constipation, nausea, vomiting. Also, this medication has not been trial tested in the Indian patient, and there is a risk of hydroxyurea discontinuation because patient think that it is a natural medicine. So patient may take L-glutamine and stop hydroxyurea. So there was a significant barrier to the initiation of L-glutamine in the Indian patients. Another molecule which was approved by US FDA in 2019 is cregenlizumab. It is a monoclonal antibody which is directed against P-selectin. In the picture you can see that P-selectin acts as a bridge between white blood cells and endothelial cells and platelets, so that the WBC gets attached to the endothelial cells and platelets. Cregenlizumab, what it does, it blocks the P-selectin, that results in non-attachment of white blood cells and endothelial cells and platelets, resulting in clinical improvement. This was the landmark trial, SUSTAIN trial, phase 2 trial, in which the patients were divided into 2 groups. One is placebo and another is cregenlizumab at the dose 5 mg per kilogram or 2.5 mg per kilogram. In the results you can see that those patients who were on cregenlizumab, there were 45.3% reduction in the annualized rate of vaso-occlusive crisis, and also more than twice as many patients treated did not experience any vaso-occlusive crisis. So it was concluded that cregenlizumab at the dose of 5 mg per kilogram showed significant reduction in vaso-occlusive crisis and delayed the median time between first and second vaso-occlusive crisis. There was also higher proportion of patients who were vaso-occlusive crisis free. And this effect was evident in many subgroups, like whether patient was on hydroxyurea or not. Even patient not on hydroxyurea, they responded very well. Also, it was effective in many subgroups, not only in HBSS patient. Those non-HBSS patients like HBSC, HBD Punjab, in those patients also it resulted in a significant reduction in vaso-occlusive crisis. So they concluded that there was either a statistically significant or a positive trend in reduction of vaso-occlusive crisis across the pre-specified subgroup of patients. And there was also reduction in the duration of hospitalization. There was very significant 41.8% reduction in the duration of hospitalization of the sickle cell crisis patient. Reduction in number of days hospitalized observed in cregenlizumab arm compared to placebo. Indication, sickle cell disease. to reduce the frequency of vaso-occlusive crisis. Dose is 5 mg per kilogram per once every 2 weeks initial dose, then every 4 weeks. As it is a monoclonal antibody, there is a significant infusion-related reaction, but the incidence is very less, 3%. One should know that this is indicated in only for the reduction of vaso-occlusive crisis and not for the actual treatment of vaso-occlusive crisis, and it is not useful for severe anemia in sickle cell patient. This is a recent breakthrough from the STAND study. They found no benefit of crizanlizumab over placebo. So this resulted in withdrawal of crizanlizumab from the market from European countries, but there is no official statement from the US FDA. There are various trials undergoing to assess the efficacy of this medicine in sickle cell patients. Another molecule is voxelotor. It is an oral medicine. It is HbS polymerization inhibitor. So it results in the reduced hemolysis, which results in increase in the Hb level. So this medicine is mainly indicated for sickle cell patients. Those are primarily anemic, say hemoglobin less than 6.5 or who experience excessive fatigue. So one should remember that this does not significantly decrease acute pain events, so should not be used for the attenuating vaso-occlusive pain. The adult dose is 15 mg once daily, not available in India till now. What about the future? Stem cell transplant, yes, definitely it is a curative option, but not in the routine use because of the toxicity involved, and also very difficult to select the patient, which patient will get benefit and which will not. Haploidentical transplant have achieved not that level of success. So, but in general, we agree that those patients who are on optimal medical therapy but not responding well to the medicine and develop progressive organ dysfunction, that patients can be put for the stem cell transplantation. Gene therapy, and just 2 months back, US FDA has approved gene therapy for the treatment of sickle cell patient and patients aged 12 years and older. It is a very attractive treatment option because it is a curative and also it does not require a donor, but cost is really prohibitive. This picture is self-explanatory. We take out the patient stem cell and we edit, we replace the diseased gene from the normal gene, and then we put it back to the patient, and there is production of healthy red blood cells. These are the newer investigational treatments, but these are under trial, so I will not go into detail. So coming to case scenario, this patient was not responding to hydroxyurea, so we started the patient, we added L-glutamine to the patient, and now patient is on this medicine for more than a year, tolerated well, not much side effects, and vaso-occlusive crisis and hospitalization has reduced. He had now only 1 episode of vaso-occlusive crisis in last 8 months. Take home message, there are new drugs available for use in the management of sickle cell anemia patients. Hydroxyurea remains the primary and mainstay of the treatment. Some patients require additional treatment for which newer agents should be used. Hematopoietic stem cell transplant and gene therapy are curative treatment options but not in routine use. Newer agents have proven to improve the quality of life and reduce mortality. Various other medicines are still under trial, and hopefully in near future we will be better able to manage the sickle cell disease patient with the newer agents. Thank you.
Thank you, Dr. Vikas, and the session is open for any question or comments.
Thank you.
Indari is not available in India.
Yeah.
And the nutrition and supplement what we have are the different isomer than Indari.
Yeah.
I have not used it. What is your experience of the available L-glutamine?
Yeah, so the Indari pharmaceutical grade is not available in India. So whatever I am using, that nutraceutical products, the whatever available in market, I calculate the dose and I am that product only I am using.
So that works according to your
Yes, yes.
experience.
In my patient, it's working. That I told in the picture that this is the challenge we face because no equivalence molecule is available in our India.
Take
Pardon, sir? Yes, sir. Prognosis?
Problem in BMT.
Yeah, so it is curative option, but looking at the risk involved in the procedure and also with the optimized medical therapy like hydroxyurea and in some patient with use of L-glutamine and crizanlizumab. So if we assess the risk and benefit ratio, so in long term I think we have to carefully select the patient. Those patients who are not responding to hydroxyurea and other medication, then only we have to consider the patient for hematopoietic stem cell transplantation because of the acute risk involved basically.
So, Dr. Uday.
Yeah, last quick query. Quick query, Nick, it's a comment actually.
Yes.
So now because you are coming from an area which has got a huge background prevalence of sickle, though all of us have an antipathy and allergy to Ayurvedic drugs as allopathic doctors, but there is a drug known as SC3. It is a drug which really works well. People have been on this drug in various parts of Maharashtra for almost 30-40 years, and the average lifespan of sickle patients without crisis is up to 60 to 65. In fact, the government has given Padma Shri to Dr. Sudham Kate he's a biochemist from BJ Medical College who actually brought out this drug and it works very well. So it's for information particularly with such high background prevalence, and the cost of the drug is 20 paisa. So SC3, it works really very well.
Okay.
Yeah. So as I said, all of us have allergy and antipathy to Ayurvedic. So we have started with the AFMC. We are doing a randomized control trial versus hydroxyurea now. So we are going to do it for 3 years to look at the actual efficacy of it in 1,000 proven cases of SCD for having a benefit. So 1,000 in this arm and 1,000 in the hydroxyurea arm to bring out that does it really help or not, or is it a genetic variation of the Maharashtra tribes where they have a higher lifespan. So is it having a placebo effect or not? We are going to work on it, but it's a drug which people are using, and if you go to Maharashtra tribal area, Satpuras, people vouch for that drug. They say that this is a drug which helps them, benefits them a lot. We have started under trial.
Thanks, Uday. Just to comment, the transplant for sickle cell disease does work very well. How you do, that's an art. So I think like thalassemia, sickle cell, all hemoglobinopathy, and the quality of life you can improve by transplant only. If you develop AVN and joint damage, and by 18 months, every sickler will have some sort of neurological dysfunction. So transplant is not that, should not be done in sickle cell disease. Very good quality of life if you do rightly. Dr. Gaurav.
Dr. Dharma has said. So I think these indications give us a wrong notion that the transplant has to be undertaken at a stage where end organ damage has happened. And the concept has completely changed now. You have to intervene early. The data shows that if you have done a transplant in a child who's less than 6 years of age, outcomes are 100%. Okay. If you do a transplant beyond that age, depending on how well you have taken care of the child, if there's end organ damage, even at a younger age, the outcomes go down significantly. So for end organ damage, which is very difficult to predict, you get to know only when you take them up for transplant. Okay, many times it has happened that we condition the patient or we take them to PTIS and their renal dysfunction manifests. So you have to pick these kids early, irrespective of what transplant you do, whether it's a full mash transplant, half mash transplant, outcomes are more than 90% if you select the right patient. And the right patients are patients who do not have end organ damage. At this point of time, there's no better way to cure these kids than offering a bone marrow transplant, which is the most cost-effective way. Okay, if you have a child who's less than 10 years, you offer a transplant, within 12 to 15 lakhs, you give the child the best quality of life.
Thank you, sir.
So this is the principle of medicine. Advanced disease, any treatment is bad outcome. Early disease, like as Gaurav said before, the years, 6-7 years, the quality of outcome which be much, much better, and this will reflect into the quality of the patient's life, long-term life. So the survival is not important for thalassemia, sickle cell disease. It's a quality of life. They can go back to society. They can lead the normal life. So,
who don't fulfill the criteria, designated criteria of doing transplant. MRI is fine, not much pain crisis, no chest syndromes. So do you transplant on?
So it's what matters is which indications are you looking at. So the indications has evolved over a period of time.
Yeah.
I would suggest you to look at the indications in 2012. There was a paper by NIH group.
Yeah,
Bolinos was the first author. And you look if you look at the indications which they used for haploidentical transplants and also matched sibling donor transplants, you will actually realize that almost 30 to 40% of your patients fulfill one of those criteria. So it's just the way we look at these indications.
Sometimes it happens that child is not fulfilling criteria,
Criteria.
in early age, but when they age like
Exactly. So you need to keep these patients in close follow-up, and as soon as you feel that they are meeting any of those criteria, which have now quite liberalized, so you need to take these patients up for transplant.
Thank you.
And we cannot predict, sir, which patient is going to suffer more. Sickle cell is very heterogeneous disease.
So absolutely, that's why you need to keep a very close watch on these patients. Okay, you just can't send them out of your radar. Rather, they are more risky than the thalassemics. So if you're given a proper treatment plan to thalassemics, they'll do much better. But these patients, I mean, what is the average life expectancy? Uday has just highlighted a group of patients in one particular region, but Chhattisgarh, what is the average life expectancy? You tell me in your follow-up, how many patients of sickle cell disease do you see who are beyond 30 years of age? Hardly you can count on fingers, 10 or 15 patients. Yes. Okay, so what happens when the incidence of the disease is so huge that every third walking person is carrier of sickle cell disease? Just imagine what's the burden of the disease and what are the actual number of patients which you are seeing. You see more anemias than actually sickle cell disease patients. Unfortunately, these patients, all of them die beyond second decade. So that's a sad story for sickle cell disease, which actually we all need to gear up and act and take it to that level. Awareness needs to be taken to that level where thalassemia is now.
Dr. Vikas, I totally echo, the comments by Dr. Dharma, Dr. Gaurav, because this audience, there are many eminent physicians from this region, and we have a sickle cell belt, not in huge proportion as in Chhattisgarh, but in our set of patients, I see maybe not even 1% of the overall sicklers in our region. We see every year 5 to 10 mortalities at age ranging between 10 to 20, severe crisis. So, and there is lot of reluctance amongst even transplanters about the, transplant outcomes in sickle cell disease. What Gaurav has highlighted is really important. The audience should carry correct message that unless and until you witness a patient, a child, an adult who has been transplanted with sickle cell disease, including haploidentical transplant. So most of the literature on sickle cell transplant is 10 years before. But last 5 years, 10 years, phenomenal outcomes. And as Gaurav highlighted, even haploidentical transplants, fantastic quality of life, PT-CY backbone, refined conditioning, better supportive care with cure rates more than 90%. So, anybody, earlier the transplant, once the child has any organ impairment, the transplant outcome drastically drops down. But before such organ impairments, and as all the eminent speakers and faculties have highlighted, quality of life is a parameter which should be really looked upon, not just life. Most of them have avian, pulmonary hypertension. You see, as you keep on tracking them over a period of time, all organ dysfunctions and all morbidities comes into picture. So that has to be kept in mind. And earlier the transplant, if the family and the society is motivated, better.
Keeping that aside, I mean, end organ damage is very difficult to predict.
Yes,
I mean, renal dysfunction, your creatinine can be normal till almost 70-80% of the kidney is gone. So it's very difficult to predict, but still, if you look at the large data about sickle cell disease, patients transplanted less than 13 years, irrespective of what the donor's outcomes are, anywhere between 75%. I'm talking about transplant which started 2 decades back till current date, so it's quite heterogeneous, but 75% to 90%. Beyond 13 years, the outcomes come down by 25%, irrespective of whether there is documented end organ damage or not.
Gaurav, because of paucity time, let's move forward and we can discuss.
Thank you.
Later. Next.
I would like to invite Dr. Puneet Jain over to take on a topic on CML management after TKI failure. Dr. Puneet Jain is a hemato-oncologist and BMT physician at Navi Mumbai Apollo Hospitals.
Is there any way to show the arrow here? In the slide, you can show the arrow.
Yes.
Show me. Just a second. So if I show the arrow, I want to show the arrow here. Okay. Forward back. Good morning, friends. Thank you, Dr. Ganesh, for this kind invitation. Conference is always a way to update yourself and meet your old friends. So my topic is on unmet needs in chronic myeloid leukemia, but I'll be probably talking more of one of the new drugs, Asimib. So if you look at survival outcomes in chronic myeloid leukemia, they have exceeded expectations, 80%, even beyond 10 years, 15 years. But there are several unmet needs in chronic myeloid leukemia, and that's what I'm going to try and focus, and some data on the new drug, new kid on the block, that is Asimib. Now, these are my disclaimers. Now, despite all the progress, there is resistance and intolerance, which is a major reason for discontinuation of treatment in CML. So it affects the quality of life, it leads to discontinuation, it often leads to suboptimal dosing, there is non-adherence, and there is switching of therapy from first line, second line, third line, when you talk about resistance and intolerance while treating CML. So resistance was actually the second most common reason for discontinuation of the first line treatment, and primary resistance, that is not able to reach the desired goals based on the ELN guideline, was the most common form of resistance that you had seen. So treatment switching due to intolerance or resistance is common, and it impacts the quality of life, and it impacts the survival in chronic myeloid leukemia. So there was this data from Quebec registry, 795 patients were included with a median follow-up of 7.5 years. What they noticed was, if you see the graphs, the intolerance and resistance were the two common reasons, and intolerance was the more frequent reason for discontinuation of the medication, as you see in the graph and the bar charts. What they noticed was switching more than twice, regardless of the cause, was linked to a poor or an inferior survival, and there was a statistical significant survival advantage in those requiring 1 or 2 lines versus requiring more than 3 lines of therapy. So these unmet needs in 2-line plus CML therapies are not being addressed by the current TKIs. So they have a higher failure rate, as high as 75%. There is 30% TKI intolerance, and the intolerance and the failure rates increase with each line of TKI that is offered. So Asimib was the first and the only BCR-ABL inhibitor that worked by STAMP, that is allowing for its binding to the BCR-ABL gene despite the mutations in the ATP binding site. So if you look at the cartoons here on the left, this is the ABL gene, and there is this the N terminus, and then there is this myristoyl pocket. So normally when there is CML, the BCR goes and binds to the ABL gene and displaces the N terminus. But in Asimib, it behaves, and it behaves like the displaced N terminus, and it inhibits the BCR-ABL gene by binding at the myristoyl site, which is a site which is different from the ATP. So all the ATP kinase domain mutations do not really inhibit its action. So this is again the difference between the Asimib and the ATP competitive TKIs. Asimib binds to the myristoyl pocket in the kinase domain, and in a non-ATP competitive manner comparison to ATP competitive TKIs. So that's the advantage of Asimib, that it works even in presence of ATP kinase domain mutations. Now this was multiple cancer cell lines, and what they noticed was the specificity of Asimib, that it binds specifically to those cell lines which showed ABL genes. So this was the first phase 1 open label dose finding study of Asimib monotherapy. This was by Hughes. This was in NEJM 2019. What they had noticed was the primary objective of this study was to determine the maximum tolerated dose or the recommended dose, and the secondary objective was to assess the safety, pharmacokinetics, and the efficacy of this drug. they realized that they had compared two groups, that is those with a T3I51 mutation group and those without a T3I51 mutation. So the complete hematological response was around 92% at 72 weeks. The major cytogenetic response was 60% and 54% was a complete cytogenetic response at 72 weeks. And the major molecular response was around 60% and 44% in two groups, those with less than 2-line and more than 2-line TKI therapies. In the T3I51 mutation subgroup, the complete hematological response was 88%, that was at 37 weeks. Major cytogenetic response was 55% and 41%. And the major molecular response was 44% in those with less than 2 or 2 prior TKIs, or more than 2 was 11%. Those who were ponatinib naive had done better than those who were ponatinib treated. So those group of patients who had received Asimib with the ponatinib naive did better than those patients who had received ponatinib before being started on Asimib. So this was the more important phase 3 ASSEMBLE study, which demonstrated efficacy and favorable tolerability profile. So the time points were 24 weeks, primary endpoint, then 48 and 96 weeks. So median duration of follow-up was 2.3 years. Again, primary endpoint was the major molecular response at 24 weeks. Secondary key endpoint was MMR at 96 weeks. And then there were other secondary endpoints: safety, tolerability, MMR, cytogenetic response rates, and the time to treatment failure, PFS, and so on. So all these key criteria were, these are all patients with previously at least more than 2 or more TKIs that they were treated, and randomization was 2:1, that is Asimib was offered as 40 milligrams twice BD in 157 patients, and bosutinib was 500 milligrams once daily, and follow-up was observed up to 96 weeks. These were the patient demographics, male-female ratio, the number of lines were almost similar, the number of mutations that they had taken, and there was lack of efficacy was the main reason for discontinuation of the prior TKI before being started on these drugs in both the groups. So this was the patient disposition. Again, if you see at the end of 24 weeks, the ongoing treatment at end of 24 and 96 weeks was much larger in the Asimib group. That means the discontinuation that was seen was much larger in the bosutinib arm in comparison to the Asimib arm. So this was a comparison of the major molecular response. The MMR rate with Asimib increased consistently over time, and by week 96 was more than double than bosutinib, meeting the key secondary objective. These green bars are the Asimib arm and the blue bars are the bosutinib arm. So again, if you look at the curves, as early as 12 weeks, the continuous MMR that was seen was higher in the Asimib arm as comparison to the bosutinib arm. The rates of BCR-ABL being less than 1% at 24, 48 and 96 weeks again was higher in the Asimib arm as comparison to the bosutinib arm. Again, this is deep molecular response. As you can consistently see, the responses were deeper and more prolonged in the Asimib arm as compared to the bosutinib arm. Other secondary endpoints that were seen were the time to the treatment failure. What they noticed was, again, the patients without treatment failure by at the end of 2 years was almost 50% in the Asimib arm versus those were 18% in the bosutinib arm. So again, the treatment time to treatment failure median was substantially longer with Asimib, which was 24 months versus bosutinib. The event-free survival, that is the proportion of patients who were event-free by 2 years, again was 57% versus the bosutinib arm. This upper curve is the Asimib arm and the lower curve is the bosutinib arm. Looking at the adverse effects, most frequent all-grade adverse effects, despite the longer duration of exposure by week 96, the safety and tolerability profile of Asimib remained consistent with that of the primary analysis, and there were no new or worsening safety findings. So intolerance in general was less with Asimib. What about the arterial occlusive events? Arterial occlusive events, if you see at the end of first 24 weeks and 96 weeks, The first 24 weeks saw 5 patients in the Asimib arm develop cardiovascular events, but all these had pre-existing cardiovascular risk factors versus only 1 in bosutinib. But continuing the drug, if you see the last the line, in comparison to the primary analysis and the current analysis, there was no increase in the cardiovascular events if the drug was continued. These are all the pre-existing cardiac risk factors. So if you look at the all-grade hematological adverse events, most hematological adverse events were initially in the first 6 months of the treatment, and recurring hematological adverse events were actually manageable. The rates of thrombocytopenia and neutropenia, that is 3.2 and 2.6, leading to discontinuation, remained the same as in primary analysis. Looking at the non-hematological adverse events, most of the non-hematological adverse events again were in the first 6 months, but if you continue, they did not persist too long beyond the first 6 months. These were the summary, that is 53% ongoing treatment at the end of median follow-up, that is end of 96, 37% had a major molecular response, and that was the primary and secondary endpoint. So if you sum it up, the ASSEMBLE study met its primary objective of superior MMR at week 24. At week 48, again, the MMR was consistently higher with asciminib. 48-week analysis, more than double of the patients receiving asciminib were still receiving treatment, and it showed a favorable safety and tolerability profile. This was again quality of life parameters. The improvement in the fatigue, feeling of the mood swings, they were less in comparison to bosutinib. The diarrhea was clinically meaningful improvement in the quality of life. As you can see in the forest plot, on the left side, this diarrhea was one important health-related quality of symptom, which was much better in the asciminib arm. So based on all of the studies, FDA has actually approved asciminib for more than 2 frontline, more than 2 therapies, resistant or intolerant drugs for chronic myeloid leukemias. This is an ongoing trial, that is ASCA first, where frontline asciminib is being compared to an individual physician choice TKI, and study hopefully will give us more clear results over a period of time. So just to summarize, unlike ATP binding TKIs that bind the ATP site, asciminib is the first and the only BCR inhibitor, ABL inhibitor, that works by STAMP. Based on the earlier study, cumulative incidence of MMR at 24 weeks was higher in the ponatinib naive patients compared with ponatinib pre-treated patients. After an additional median follow-up of 5 months, asciminib continued to demonstrate sustained efficacy compared with bosutinib. Safety profile is of asciminib remained consistent with that of the primary analysis, and there were no new or worsening safety findings. Updated efficacy and safety results continue to support use of asciminib as a new treatment option. Thank you.
Thanks, Puneet. Because of paucity of time, we can take questions outside, but we'll move to the panel discussion first.
Sure.
Thank you.
Thank you.
For the panel discussion on multiple myeloma in 2024, I'd like to invite Dr. Ashutosh Panigrahi to moderate the session. Okay, I would like to.
Heartiest thanks to Dr. Ganesh for this invitation and nice conference. So there is so many requests for leaving the session and change in the discussion panel. So with me for today's discussion on myeloma 2024, I have Dr. Abhijit, probably he has left already, Dr. Shaikat, he is there, Dr. Ankit, Dr. Padmaja, Dr.
SVSS Prasad. Yeah, all these are not there. So in place of other panelists, I will request Dr. Radhika and Dr. Krupa Bajaj to please join for this panel discussion. So moving forward quickly, we all know that when we suspect a case of multiple myeloma with bone pain, renal impairment, anemia, we do panel of tests to diagnose whether the patient is having a clonal plasma cell disorder, more than 10% bone marrow plasma cells, and features of SLIM or CRAB. After that, we re-stratify RISS commonly done, which has a prognostic significance. Then our goal of treatment is induction, consolidation, then maintenance, and treatment at the time of relapse. So we all know that one, and we see the response to our treatment as per the IMWH guideline. But when I went through the ASH 2023 and 22 updates, I was really confused. So in 2024, how I will treat a multiple myeloma? So I think my panel members will help me in dealing with the cases in day-to-day practice. So by through case scenario, I am discussing cases. This is a 51-year male smoker presented with back pain, having type 2 diabetes mellitus. Performance status is good, vital stable. Laboratory workup, we did all the myeloma related workup. So now it is diagnosed as multiple myeloma, standard risk stage 2. So any panel member can give their opinion. My first opinion, should I do a PET-CT at baseline for evaluation of multiple myeloma? Because now most of the papers in 2022-23 guideline, they are based on MRD, and in that the discussion is on PET-CT.
I do MRD for every case.
That means MRD should be done routinely in your clinical
PET-CT, not MRD.
Okay.
PET-CT I do for
So
every
for
case.
all of your patients, you do PET-CT?
Yes.
Any opinion from other members?
So for baseline, if a low dose CT is available, I do not go for PET-CT in all the patients. Just to look at the bone status at baseline is optimal.
Okay. Any?
Yeah, I do in all the patients. Unless they're not affordable, you can get away with skeletal survey. There are 2-3 reasons why we do a PET-CT. Sometimes it upstages a smoldering myeloma when you have a bone lesions. That's the time it started off where we had the skeletal survey not picking up a smaller lesions, PET-CT picking up. That's one reason it started off. The second thing, another thing in multiple myeloma, we do a bone assessment is to see a prophylactic pinning to prevent fractures before it fractures in the treatment arena. And PET sometimes fail to do that. You have a lytic lesions, but you don't know they're threatening to fracture unless how you pick up on X-rays. Sometimes you go back and do an MRI of the hip where the pain is there. So that's a limiting thing. And one PET is end of treatment to see that PET negativity has achieved while we're talking about a young patient having a deeper responses. Those are the reasons we do these scans. Yeah, I would by default unless financially concerned.
Okay. So yes, madam.
We routinely do PET-CT nowadays. Yes, we used to scoff at PET-CT once upon a time for myeloma patients, but now, yes, we routinely do. And I do agree with Dr. Padmaja on all the other aspects.
I'm in a government sector, sir. I still follow the old regimen of skeletal survey, but yes, definitely we should be upgrading to the PET-CT.
I would like to differ with some of my panelists that in a multiple myeloma, it's a lytic lesion, it's not a sclerotic lesion. Usually in PET-CT, the uptake will be really better when it's a sclerotic or mixed lesion. So in multiple myeloma, all the guidelines do suggest low-dose CT. The reason is it's a lytic lesion by the sense. Unless patient is having a soft tissue deposits or extramedullary myeloma, PET-CT is not going to add really more value or it's not more sensitive enough. So whole body MRI or whole low-dose CT we are actually following right now. And MRI is more sensitive than PET-CT to pick up the lesions well.
Okay. So it is a varied response. So I think I have done in this patient because this is a state government funded patient. So and our institute has that facility, and the patient presented with multiple site lesions. So with 3-4 plasmacytomas clinically. So that's why we did it. But otherwise, in my practice, I choose a low dose CT. So PET CT, I still feel ki it is experimental till now. If facility is available and in case to case basis, if it is needed, that will be a better option. But it is clinician's choice. That's a very, I take into consideration this one. My next question is fees. I think most of us are now doing a risk assessment by genetic mutations in this patient. So everyone will agree, or any differ in opinion? No. Okay. So we'll move forward. So it is a multiple myeloma standard risk stage 2. So now these are the all regimens based on the clinical trials, Griffin trial, so many trials are there. So what I will choose? So I will learn from my audience, my panelist. So many options upfront. In 2024, what you will do?
So it's a standard risk patient, transplant eligible. What you are asking actually multiple questions, that should we use 4-drug therapy in a standard risk patient?
Exactly.
So we have trial data, we have Griffin trial data with a phase 2 trial, randomized, and also Perseus data, both of which showed that 4-drug therapy with adding the Tumumab add to extra deeper response, and we have PFS advantage. So we can give data with BRD for the standard risk patient also. Now, second question you are asking with your F choice, that should we obviate with do I with transplant or not? We don't have data now. By using daratumumab that we shouldn't do transplant, we don't have that kind of data. And third is, should we use dara in our maintenance therapy? So in this Perseus trial, they use dara in maintenance, and if they are MRD negative, then they shift it to only LEN. But there are previous data like Cassiopeia where it showed that if you use dara in your induction and consolidation, possibly maintenance dara won't help much. And there is also added risk of infection and cytopenia. So I won't use in maintenance therapy. Obviously, if patient is affordable, I will use dara with VRD in upfront and then transplant and consolidation.
Dr. Bajaj, any opinion?
Yeah, sir. So the recent ASH 2023 presentations, whatever happened, it included high risk as well as ultra high risk. The predominant data is there with the addition of dara. Standard risk, I still stick on my foot to VRD, AST, LEN maintenance. Unless patient is really super affordable, I really don't offer. Like, yeah, this is my stick. Like, though trials, like as I echo with my other panelists, addition of dara or maintenance dara is shown some benefit, but cost effectiveness, pertaining to cost effectiveness, I do offer in only high risk and ultra high risk.
Okay. So what I conclude from opinion, any varied opinion in this regard?
The same, sir. What we actually practice, most of the hematologists here practice is frontline VRD followed by consolidate with a transplant and LEN maintenance for a standard risk.
So in this regard, one question to my panelists. So which thing in your clinical practice affects most in choosing daratumumab in your patient? It is the cost or anything else?
High risk patients, in relapsed patients.
So upfront, in this is a newly diagnosed one. Upfront use, where is the limitation?
So disease with a bad biology, mainly the high risk based on the cytogenetics, is a group where we would offer dara, but definitely finances are adequate.
So I think as per the data and what we are doing, there is a great variation in what is done in routine practice. If you come to real world scenario, probably only few clinicians are using upfront daratumumab. I think cost is the main factor, but if we consider in a different other way, what is scientifically should be proven, in Indian scenario or in most of the malignancies, first chance is the best and only chance you can get treated a patient. So in that regard, if there is no other hindrance in use of daratumumab, my opinion should be offered to the patient. But one thing in my doubt, that if we are using all the 4-5 drugs in upfront, suppose the patient relapse, so I have limited option. If I am using less and I am preserving something for later, is my thinking rational or I am irrational?
If the whole idea is to hit the patient hard upfront and wait for the relapse to get delayed, then I think you should not be really worried.
That data tells, but a real world scenario may be something different. Okay, so this is a point of research. Probably we may work on this.
Survival data for
okay. So long-term data can solve this problem. So till that we have to wait.
Certainly our thought process was that you want to save some for your basket for relapse.
Yes.
Until the time we started following MRD and getting a deeper remissions, we want to use more and more drugs upfront to get a deeper remission, to get a longer PFS, so we can reuse the same treatments and so on.
Okay. So my next question is post-transplant consolidation. Because POSTIOS trial, what they have done in 4-drug induction, followed by autologous transplant for all, and after that they have given consolidation for another 2 cycles. Is it justified?
For my patient, I give of any high risk, we give consolidation. But standard risk after transplant, I ship them to usually land maintenance.
Okay.
Yes, so for high risk, for sure, I do give consolidation 2 cycles. I do offer that. For standard risk, as other panelists suggested, I don't really offer the 2 cycles consolidation. I just go for maintenance straight away.
So I think
our transplant is get delayed by 6-7 cycles. So already those 6 cycles are given.
okay. So what I am excluding the time frame, I think the conclude remark will be in high risk patients we can consider this one, because previous trials have shown there is a progression free advantage, but overall survival advantage is not there if we are giving a 2 cycle or 4 cycle consolidation post ASCT. But definitely it has some progression in advantage in progression free survival. So okay, moving towards the next, which of the following, suppose theoretically this patient is not transplant eligible. So what will be our option in 2024? So whether still it is a triplet or doublet can do, or a DARA should be a important induction regimen in this group of patients.
I would still go with the first option, and DARA we have discussed just now all the ifs and buts of DARA. So till such data is more compelling, I would still stick on to the first option.
Okay. So for real world scenario, I think that is the most suitable and valuable point. Obviously, in more fitter and older patients, I think consideration of DARA should be given if affordability is not an issue, because they have a limited survival time where they should have a deeper response and a better quality of life. My thought process is like that.
The problem is that
Probably
we don't have this head-to-head trial, like we don't have VRD versus DARA RD. Now, Maya trial, they have shown DARA RD is better than RD. This month, few days ago, one data was released that's not a randomized trial, it's TORUS registry, some kind of real-world data. So they compared DARA RD with VRD, and DARA RD showed less chance of death and less chance of progression. Okay. So if patient is affordable, as we are not doing transplant for deeper response, it's better to use DARA upfront, and possibly maintenance would be difficult for this group of patients because infection is really problematic in India, and they have repeated episode of pneumonia and sometimes reactivation of tuberculosis or these things happen. So sometimes these are fatal.
So I think it is a great question, that sequencing of drugs in myeloma. So we have, as per the comorbidities and availability of the drug, affordability issue, we can take off one and add subsequently in this group of patients. Okay. So moving to next, this is the real world data that I am showing. It is of study or of any trial. So we probably, these are the options what we can offer to our patients, whether it is a transplant eligible or ineligible, but definitely trial situation is something different, and this is the patient who are transplant eligible. So going towards the case 2, it is a 43-year-old male alcoholic smoker, type 2 diabetes mellitus on oral hypoglycemic drugs, CVA 2 years back, presented with backache, and on evaluation the SFLC ratio is high. Other laboratory workup all are in favor of a multiple myeloma, and the final diagnosis is a high risk multiple myeloma newly diagnosed. So with this, the newer concept that has come in 2024 is functional high risk myeloma. So what is your opinion from my panel
Yeah, sir. I strongly agree with this new concept which got evolved. Even it's very interesting to see TP53 copy numbers also does matter. It's not just TP53 positivity also. So high risk and ultra high risk, definitely it's a new concept, but it's going to get established concept sooner.
Okay.
And they are doing molecular analysis in abroad, like even whenever we interact with the people who are doing in abroad, they do say they're doing a molecular profiling and NGS in multiple myeloma to pick up the copy numbers of TP53. It's not just TP53 positive what we do regularly. Yeah.
So then can we practice this one in our general practice now?
It depends on the availability from the lab, I believe.
Probably
yeah,
no.
Yes.
Probably no.
Yeah.
Probably no. We cannot do it because it takes help of NGS and all other MRD parameters. Probably that is not doable in all these situations. But if at all someone wants, and in trial basis, we can do this one. Okay. Any opinion, Ankit?
So in my understanding, functional high-risk myeloma are those. So basically, the disease burden, disease biology, and response to therapy. These are the three things which we are looking at when we are treating a patient. So functional are those who actually we would classify standard based on the biology and the burden, but they do not respond as well to therapy as we would have wanted them to. These are the ones which are difficult to pick, and I agree that based on the genomic data, those are the ones which are maybe classified, would have been classified as a higher risk. But in clinical practice, it is very difficult to pick them up because it is only the response to therapy which will guide us. And later, they end up relapsing very early after transplant or not doing well. So extremely difficult to pick them.
Okay. So one thing I want to suggest in this condition, suppose a patient is having a T53 mutation. This is the biology. And in tumor, as the tumor progresses or as you go on treating this patient, definitely a T53 mutated myeloma and a 614 mutated myeloma will not behave clinically same. So in that regard, what I think, a functional high risk can be easily picked up by LDH level. That shows the disease burden. Is it possible?
So again, high LDH, we are already classifying them on the RISS scale as functional, as having a high disease burden. So we are already doing that. So functional, to my understanding, was those whom we are not able to classify as high risk. LDH is a established marker. If it is high, it is high risk.
We have to take help of other parameters to justify who are the actual functionally high risk myelomas. So then now how we are going to treat this patient, high risk, newly diagnosed multiple myeloma, young, transplant eligible?
Yeah.
Quadruplet or quintuplet is like going to be, it's an established evidence is there, sir, in high risk or ultra high risk myeloma.
So 4 drug induction followed by transplant?
Yes, and also maintenance with 2 drugs like DARA plus.
Yeah. Okay, fine. So when you are using daratumumab, how it is affecting your clinical assessment of response to treatment and how you are going to assess response in them? Anyone can.
So in whatever the high risk or ultra high risk, it is good to know this patient is high risk. That makes us to make a decision about quadruple therapy for definite. And in a patient who is standard risk, I know I'm going back a bit, with multiple comorbidities, what we see in real life, they're diabetic, you can't deliver a 40 milligrams dex, which is part of most of the backbones in this. So you're actually under-treating these particular patients, and you're not able to give a full dose of len. So in those kind of patients who are affordable, I would offer a quadruple therapy, which would allow you to deliver at least an effective therapy which you could cascade to the effect of your response rates to the one in the trial without the triplet. So that's one. Definitely serological assessment, and if possible, end of 4 cycles, I would do a cytogenetic remission assessment, which would equate to your MRD. If they were a PET positive, I would repeat a PET if there's ultra high risk to see that they've become PET negative, cytogenetic negative, serological negative, marrow negative before I take them through transplant. Suppose if somebody had a positivity, then you would do a post-transplant consolidation with 4 more cycles, because this patient is an ultra high risk who's going to relapse very quickly, followed by bortezomib maintenance. There's a little bit of debate about a combination of maintenance versus single, but if you've used another 4 cycles post-transplant consolidation, it's very difficult for the patient to tolerate a longevity of those combination therapies, I would think.
Nice, madam. So definitely many discussion has been done in recent hours, many articles has been published on MALDI-TOF. So anyone can comment on that? Assessment of myeloma during remission, MALDI-TOF gives mass spectrometry that also obviates this daratumumab interference in assessment. So nowhere it is recommended in any guideline, but big discussion was on this topic. So I think it is experimental. In near future we can see whether mass spectrometry, MALDI-TOF mass spectrometry can identify a group of patients where a residual disease is missed when the patient is on daratumumab. Definitely we all know that broad grouping and RS typing should be done previously, so that during post daratumumab there should not be any interference. So these are the literature results how we can tackle this situation. Now moving towards the case number 3, 36-year female, no previous comorbidities, anemia and renal failure, M-band 0.22 gram per deciliter, SFLC 493, bone marrow 40% plasma cells, FISH myeloma negative. So IgG kappa, multiple myeloma, RISS3, severe renal impairment, on dialysis. So now my question is daratumumab safe in patients with renal failure? Because this is the most discussed drug in recent advances.
Absolutely, daratumumab is safe. We can definitely administer it.
So subcutaneous daratumumab, any experience on this?
I actually tried to procure the medicine
because it is going to be launched in this
I actually tried to procure this medicine for one of amyloid patient recently, because volume was an issue, administering volume. So the exorbitant cost prohibited us from doing so. So once we have it, maybe ease of administration is definitely going to be there with subcutaneous dara.
So as per your experience, the patient where you have used, it is a doable job, no problem.
I have not used. I have tried, but because of the cost, I was not able to.
Fine.
Subcutaneous data not tried, create clearance below 15. Like IV data we can use in this dialysis patient also, but I don't know about subcutaneous data. They are not tried.
Okay, so it is not available. Probably on next meeting we can discuss about on subcutaneous. We'll forget about intravenous.
Subcute dara I have used in UK when I practiced, which is easier in renal impairment patient. You're not worried about dialysis. Even the literature says you can get away with the dialysis, but I'm always quite concerned about giving dara just before the dialysis. So I always place my dara soon after the dialysis so that it is not filtered out. Subcut has got no issues and a fluid overload, as you're saying. That's, but the response rate seems to be the same, but the dose is bigger, which is the standard as per the monoclonal antibodies.
Okay. During
while dara is the point of discussion here, bortezomib still stands high in these renal failure patients.
Agree, 100%, because this is the real world where bortezomib, all renal impairment, we revert it by bortezomib only and dexamethasone. Okay. So does daratumumab affect stem cell mobilization?
Some effect is there, but like dara treated patient, they require more prelic support. But you can harvest, like you can able to do transplant. But the stem cell dose what you acquire from patient is lesser than like VRD versus dara VRD, and more prelic support is required in dara group.
Okay. So moving to next case, 52-year-old male diagnosed as standard risk multiple myeloma, treated with 4-fraction VRD, then ASCT, started on LEN maintenance 1 year after relapse. So it is a early relapse, standard risk multiple myeloma on LEN maintenance. So the discussion is role of MRD monitoring in our clinical practice, because if we detect early, treat aggressively, probably we can avoid early relapses. So what will be your opinion in our practice, what we should do?
In my practice, I am not even sure about the MRD report I am getting for my AML or ALL patient. I don't think of sending flow for myeloma.
Okay, okay, fine.
Certainly, like MRD monitoring is still a point of discussion in all meetings of multiple myeloma. It's good to do it, but none of us are doing it. Even the people who are like practicing abroad, they're also not stringently monitoring MRD unless a trial patient is there. In trial patients, once in 3 months they are doing so, but regularly they're not doing.
So
be done in-house, as the plasma cells are so frail,
exactly.
And they get clotted up in the samples, even in flows you don't pick up. So I think there's a lot of practical issues.
Okay. So the conclusion is that most of the studies that has been published in 2023 all are means MRD based. So we are not able to do it because of some logistic issues, and it is not available also, and there is no standardized laboratory which can provide you the report. So that's why you are not doing. So in that regard, if it is available, I think it should be done so that we can give a better better disease control, and we can increase the progression-free survival or overall survival. Achha. How would you treat this patient who has relapsed?
How is the MRD assessment going to change the treatment strategies? It's not a very gross.
Yes, whatever TADA pursues trial is there, they have down-regulated the treatment if the patient has gone into MRD negativity. But who are MRD positive, it is not a big deal what you are going to do.
What do you mean by down regulation? Where did you down regulate?
They are curtailing the maintenance. They are curtailing the maintenance.
Okay, but
yes.
not in the regular practice of VRD transplant and all.
But what I can tell, in one patient I am telling, he is a high risk multiple myeloma, 60-year-old. We started with VRD as per our usual practice. After 3 cycles, I did the SFLC ratio, LDH, and serum protein electrophoresis, urinary electrophoresis. Urine electrophoresis is negative, SFLC is 20, and M-band is absent. So then I did, after 1 cycle, again did the same, and it is stable. And he is telling that whatever drug is available you give me, I want a good life, what to do. So in that condition, I added daratumumab. After 2 cycles, he went into remission, transplant is done, and now he is okay. So these are the situations where MRD can help. If at all we have started with a different regimen, and now we are going to change, probably in near future we will, when it will be available, probably we can have a clear picture how we can incorporate this MRD in our clinical practice. But I think it is a good thing, but at present it is experimental. In near future, if at all things will change, then we can use this one. Tandem transplant. Now in 2024, what is your opinion?
With the new advent of drugs combination, quadruplet, quintuplet, tandem transplant will not hold good, sir. That's my opinion.
Okay, so that is probably.
So for this patient, I won't recommend because relapse within a year. But I think in India, it's still like we can do it because it's less costly. If you have stem cells stored after first transplant, like it would be like cost benefit ratio would be there if you use continuous DARA maintenance or then newcomer drugs like BITE or CAR T cell, it would be less costly.
Can we do a second transplant in this situation?
Not for this patient because it relapse within a year. Usually patient who relapse within 2 years of transplant, repeat transplant doesn't work. Repeat autologous, we can still do allo but not autologous.
Okay. So autologous transplant, a repeat or second autologous transplant in this patient is not an option. And second thing is tandem transplant upfront in high risk patients is also not well practiced, or now no one is practicing unless it is a experimental thing. Okay. Okay. So moving towards the next, these are the some data from real world data. Now coming to the case number 5, 52-year male, diabetes mellitus, hypertension, and diagnosed as multiple myeloma under evaluation for hypercalcemia and pathological hip fracture. The laboratory workup tells that it is a patient. Then a patient of multiple myeloma started on VRD, progressed on 3 lines of therapy. So patient is relapse refractory multiple myeloma. So great thing has been discussed on this relapse refractory multiple myeloma. So what is your option for this group of patients? Obviously, so these drugs are not available, and I think we should try and combinedly do something so that our patients can get this type of drugs available in India.
In compassionate basis also they are not getting. I have tried for 2 of my patients, so they are not getting BITE or CAR T cell.
So I think we should try.
We should have more trials, clinical
here.
trials to enroll patients.
So clinical trials like what patient I refer for them, they are really bad patients. So clinical trials for CAR T, BITE, compassionate basis, they are not getting it anymore. And CAR T trial running in India, they are not taking those bad patients.
There is one more new clinical trial coming up with oral medications, that CBP P300 blocker, which a bromidine domains deacylator epigenetic molecule with origin is coming up with the AUR107 trial is coming up for these kind of patients who are relapse refractory, no more therapies, and CAR is not an option. Maybe it's something we can think about.
Okay. So definitely I think that still allo transplant has some role in our setup where we do not have CAR T and all these things. So in this group of patients, probably if the patient is young, match is available, we can consider allo transplant in this group of patients. Okay. So with this, I summarize what I learned from all my esteemed and learned panelists, that a newly diagnosed multiple myeloma, 4-drug induction regimen followed by transplant for all, followed by 2-drug maintenance or 3-drug maintenance for high risk and LEN maintenance for low risk patients. And those who are transplant ineligible, 3-drug combination is still the option. When the patient relapse, same DARA-based treatment if not previously done as per the comorbidity and previous drug use, we can think of giving all the drugs what is available, and simultaneously if it is more than 3 years we can reconsider our transplant. And in refractory diseases, we should try to find out ways to get available these drugs when it is when possible. So low dose CT and target imaging is sufficient. Tandem transplant is experimental. Post transplant consolidation not provide added advantage, but can be considered in high risk cases. Search for opportunity to make newer drugs available should be our target. With this, I thank all of my panelists and the organizer. Thank you.
Thank you. I think we'll close the session.
We humbly request for all the faculty speakers and chairpersons to proceed to the faculty desk after their respective sessions. Let's break for a quick tea for 15 minutes, and the next session will resume at 11:35.
Good afternoon, everyone. I would like to invite chairpersons for session 7, Dr. C. Sai Ram, Director, Senior Consultant Oncologist, Swarnasai Hospital, Hyderabad; Dr. Kripa Bajaj, Consultant Medical Oncology, Indo-American Cancer Hospital, Hyderabad. Kindly address the session, sir. Thank you.
I thank Dr. Ganesh and Yashoda Hospital for inviting me as the chairperson of this academic feast. We have seen from yesterday and that we have almost covered everything about hematology, what postgraduates, consultants, oncologists, general medicine doctors have to know about it. So we'll have first speaker, Dr. Ganesh. I think we need not, I think everybody knows about Dr. Ganesh, but still I would like to give my association with Dr. Ganesh. I've made him as a scientific committee chairman for our IMA while I was IMA City branch president and IMA AMS Telangana chairperson. I have seen him participating in almost all hematology and oncology conferences, and he spares all his, most of his time he spends in academic activities, and you have been witnessing for this last 2 days. And I think apart from academics, he takes care of patients. He has taken care of a lot of my patients very well. And ultimately, whatever doctors in Telangana cannot treat hematological condition, ultimately lands up with Dr. Ganesh, at least from Telangana point of view. So Dr. Ganesh will...
Thank you so much, sir, for the kind introduction. Good morning, everyone. At the outset, on behalf of Deccan Hematolink, I would like to thank each one of you for sparing your weekend, Saturday, Sunday, coming all the way here, and exhaustive sessions yesterday. From morning 9:30 to evening 6, the hall was always full. Today is also for a specialty like oncology. Having these many numbers is really heartening, and we are really grateful to all of you coming from all the corners of our country. Most of them are the experts in the field of hematology, bone marrow transplant from our country, authorities, and I am really thankful and grateful to each one of you for sparing the time together. I hope everybody has good academics and a good time together at Hyderabad. So the topic of today's presentation is transplant conditioning protocol. I know there are many eminent physicians, pediatricians in this auditorium, but I will focus both basic and advanced portions of transplant conditioning protocol. So again, once again, heartfelt thanks to all of you from Yashoda Group of Hospitals, High Tech City, and Deccan Hematolink. So when we talk of transplant conditioning, how important it is. We are all movie lovers in the South, and this is one of the nice movies depicting the perspectives not just from the patient but from their caregivers. This was a very nice movie, Sky is Pink, where this girl, this is a real life story, Ayesha Chaudhary, who has PID, and she goes to the, once upon a time, of course, all these facilities are available here in India. So many PID experts and authorities, world-renowned PID experts and authority are sitting in this auditorium. So, but that was a time about 15-20 years back. People have to travel all over to get such kind of complicated transplants. So primary immunodeficiency disease, this girl ends up doing her transplant at Great Ormond Street Children's Hospital in UK, London. And despite having a successful transplant, she progressively develops, there is something called as transplant conditioning. which is high dose chemotherapy to destroy the diseased bone marrow. So busulfan was the drug which was rampantly used before. Now there are multiple alternatives, and because of this drug, even though the transplant is successful, this girl is cured of her deadly primary immunodeficiency disease. She develops progressive lung fibrosis, lung failure, and she succumbs to idiopathic pulmonary fibrosis post-transplant lung failure. Of course, nowadays even lung transplants are on a rapid rise with improving outcomes across the country. So this also can be tackled in the current era, but just to show you, despite the disease being eradicated, patient getting completely relieved of her disease, conditioning chemotherapy can have various impacts, including it can be the cause for ultimate mortality in successful transplant patients. So again, this is Bollywood on regimen related toxicity of allogenic stem cell transplant. So the outline of my talk is I am going to talk everything about transplant in a given short period of time. So the goal of conditioning, we know two important goals: immunosuppression, because just like other transplant, the allogenic stem cells from the donor should not be rejected by the patient's body. So you need to immunosuppress, and cytoreduction, particularly in conditions where transplant is done for hematological malignancies, because high dose chemotherapy can completely kill the cancer cells. And this is by this Gompert's law, we all know that the higher the chemotherapy dose, higher or maximum is the tumor kill, and that eventually if you keep on increasing the chemotherapy dose, there is a point when bone marrow becomes irreversibly damaged, and you continue doing further high escalation the chemotherapy, there will be irreparable lethal other organ toxicity. So somewhere between lethal bone marrow and irreversible organ toxicity, we devise a conditioning dose which will destroy the bone marrow but which will be non-toxic to other organs. By doing this, you kill the cancer in maximum amount, and that's the ultimate goal of transplant for malignant indications, complete cure from the malignancies. Again, this is depicted from this slide. You can see in a patient transplanted with various conditions, leukemias, you see those patients with no graft versus host disease has the worst outcome compared to those patients having acute and chronic graft disease of various intensity. That depicts that the second objective of transplant is, apart from high dose chemotherapy, something called as graft versus tumor effect. The stem cells from the donor keep on attacking the cancer, not letting it come back. And again, this is again relapse post-transplant. This is a very nice data set from CIBMTR data. There are two types of relapses. The first one, A, high-risk malignancies, where before the graft versus tumor sets in, the cancer relapses. So here, these are the patients, high-risk malignancies. You need to really smartly devise the conditioning dose. The second set is B, where probably graft versus tumor effect is not robust, and that's the reason why the cancer comes back. So you have to balance both these things, the conditioning intensity and the the graft versus tumor effect over a period of time to prevent the disease malignancy coming back. These are the various conditioning intensity regimens devised by CIBMTR. Basigalupo published it in BBMT 2009. I will skip it. But you see, simple busulfan, common drug used for transplant, the impact of dose on the transplant conditioning, higher the dose, higher is the tumor or the long-term cancer-free survival. So again, this was the only paper, BMT CTN trial published by Scott in JCO 2017. You can see this is the only prospective trial where they have shown that patients with myeloablative conditioning for leukemias like AML and MDS, the relapse rate is lowest, the lower curves are the relapse-free survival, whereas the patients with these diseases, reduced intensity, higher relapse. And that's why you need to devise the conditioning intensity to let adequate cancer control, let adequate cancer-free survival on long run. So these are various drugs and these are the various diseases depending upon the aggressiveness of the malignancy. Again, conditioning intensity has to be devised. The aggressive leukemias like AML, ALL, you need to have more myelosuppressive, more myeloablative conditioning, whereas the indolent disorders like CLL, CML, myeloma, large cell lymphoma, you can devise a less myelosuppressive. Again, we count depending upon the type of the donor graft, intensity of the immunosuppression have to be modified. If it is simple mass sibling transplant, you can end up with simple protocols. But if it is unrelated alternative donor transplants like haplo or unrelated donor transplants, increasing genetic disparity, you need to intensify the immunosuppression to prevent the graft rejections. So again, this is just a rough figure. The more the myelosuppressive conditioning chemotherapy, the higher is the day 100 transplant related mortality. You can see reduced intensity 2 to 5%, and as you go on 5 to 10% and sometimes 10 to 15% if it is absolute myelosuppressive intensity. And this is intensity based various drugs falling in this plot. And another important factor is age of the patient, comorbidities, and this can be, again, this is a CI-BMT data set after age 40. You can see the curves are broadly splitting and continuing to split till age 70. The higher the age, higher is the mortality with myeloablative conditions. So all these factors have to be taken into consideration. Again, this is the fantastic brainstorming idea by 3 groups parallelly, including Dr. Reynostraw from Seattle, conceptual development of reduced intensity transplant starting from 90s, and that has really has been the transformation in transplant eligible patients. So with this reduced intensity conditioning, we end up with mixed donor chimerism, which will lead to some kind of GVL, graft versus host disease, graft versus leukemia, and which will control the disease, and long run these patients will eventually turn full donor chimerism with complete cure of various diseases for which it is done. So again, this is the conditioning intensity. Depending upon your purpose, disease, patient related factor, you have to devise smartly. And again, this is just a graph about which diseases are more amenable for GVL, CML, Hodgkin's lymphoma, CLL. You can see GVL is 50 to 80%, whereas high grade leukemias and lymphomas, GVL is less robust. So you need to devise more intensive conditioning in these regimens. Of course, there are multiple factors which are taken into consideration before devising the conditioning intensity. Again, the puzzle about reduced intensity and myeloablative is unsolved. Depending upon the way, as I mentioned, the Squats paper in JCO was the only paper which had showed a benefit of myeloablative conditioning for AML and MDS, but other than that, other trials failed to show any benefit to anything. Eventually, both trade off same. So changing gears further, what has been developed over last 10-20 years about refining the conditioning intensity. This is one of the papers. Conditioning with decreasing toxicity without losing anti-leukemic efficacy by adding the fludarabine in the busulfan backbone in place of cyclophosphamide. And you can see the results are nicely separated out, and this shows that the more better conditioning with fludarabine based conditioning rather than cyclophosphamide, the alkylator, the 5 nucleotide inhibitors leads to better improvements in the outcome. Again, another backbone, triosulfan, after 2010 onwards, triosulfan compared with busulfan. Again, you can see the blue curves are triosulfan, the curls are clearly separating out, and the separation continues to be maintained on long run. And this, the triosulfan based conditioning, less toxic, more potent, equipotent, the long term outcomes are better with triosulfan based conditioning. This is because of their biochemical properties, less veno-occlusive disease, less TRM on long run, and you can see this has translated into better overall survival and leukemia free survival long run in triosulfan based backbones, particularly for high risk leukemias. Again, another conceptual wavefront, double alkylator with thiotepa plus any other alkylator. So it was initially used for cord blood transplant, but nowadays across subsequently myeloablative haplo, and now even with the match sibling transplants, both benign and malignant indications. And again, to cut the long story short, outcomes were better. So double alkylator based protocol like TBF in high risk AML, again you can see the curves are separating out. The upper curve is patients having active disease. Almost 1/3 patients have active disease, 2/3 patients have high risk leukemias, and despite this, normal 20-30% outcomes in difficult to treat patients. With these double alkylator based protocols, the outcomes are close to 60%, as good as any other standard risk leukemias. Again, this is a German concept, sequential therapy, mostly Flamsa-Rick. Again, the outcomes were much better compared to the traditional backbone. And when we compare all these new wave fronts together, Flutrio versus TBF, double alkylator versus sequential Flamsa, and you see the curves are just superimposed on each other. So, this was again a very large database EBMT retrospective analysis. That is very, very important. So depending upon your institutional protocols and your adaptation to this protocol, your confidence on these protocols, this will suffice to your purpose. And switching gears further, so an optimal conditioning regimen will be something which will allow consistent engraftment with maximum malignancy elimination with minimal toxicity. Most importantly, reducing toxicity without compromising transplant efficacy. And this is how there are novel, newer concepts, reduced toxicity concept. One of them is again targeted, pharmacokinetically targeted IV busulfan, IV fludarabine and triosulfan. The number of eligible transplant patients are increased because of these refined conditionings. And also there are many factors, age and patient related and disease related factors which will define the long-term outcomes across various. So there is paradigm shift in our understanding of the conditioning. You can see the conditioning protocols before 2010 and after 2010. There is a huge sky change in the outcomes for all advanced as well as standard blood cancers or non-malignant conditions. The outcomes are improving and they are on the improving trend. Hopefully in the future the outcomes are going to be much more refined. So again, this is you can see the number of patients eligible for transplant above age 60, 70 is rapidly increasing. This is because of this refined conditioning and better supportive care. And this is the CI-BMT data set. You can see myeloablative and reduced intensity conditioning various drugs. And this is Indian Society of Bone Marrow Transplant, our own data set, our own alternative donor transplants, our own transplant split as well as the disease split and the conditioning. So important clues. Conditioning considerations, most important is time sequence of drugs in the conditioning. If it is a fludarabine with alkylator, fludarabine should be given 2 hours prior to these alkylators like busulfan, triosulfan. Timing of ATG, I will skip that. Dr. Rajiv is going to talk about this. That is also an important parameter. For alternative donor transplants to prevent graft rejection, mostly we are relying on TBI, 4-grade TBI. But if some centers where TBI facility is not there, we can use radiomimetic T lymphocytotoxic drugs like thiotepa. Early ATG to eliminate mature host T cells and thereby decreasing the incidence of GVHD. Novel salvage like inotuzumab and gemtuzumab are on the rise in various leukemias. Those patients who are exposed to these novel drugs, the complications post-transplant in certain disease-related subsets are high, like hepatic veno-occlusive disease. Here you should avoid dual alkylators. Again, for immunocompetent hyperactive marrow like thalassemia, sickle cell disease with alternative donor transplants, to prevent graft rejection, we have to add pre-transplant immunosuppression at least for 2 months. And what is just another 2-3 slides. What is new in conditioning is this is the future targeted conditioning with radiomimetic, radio-labeled isotopes. And one of the paradigm change which most of us have adapted to over last 5-6 years is from this landmark paper BBMT 2020. The impact of augmented TBI initially in the aplastic anemia, now in all disease subset. You can see the outcomes from 2-grade versus 4-grade, there is 20% split. And I'm sure most of us are now adopted to 4-grade TBI for all alternative donor transplant to prevent the graft rejection. This is how to improve outcomes. There are multiple factors which can influence, and hopefully thinking differently, we are going from the traditional one treatment fits all to personalized medicine even in the field of transplant conditioning. So to summarize, conditioning chemotherapy forms the backbone of transplant for most hematological disorders and hematological malignancies. In various randomized controlled trials of different conditioning regimens, reduced toxicity has decided the race rather than difference in the efficacy. Intelligent dosing strategies might help to improve outcomes by individualization, avoiding both over and under exposure. And most important is institutional expertise. Adaptation is the key factor in devising the transplant conditioning and deciding the outcomes in our subset of patients. With that, I thank all of you for your patient hearing, and if the chairpersons permit, I will like to address the questions, 1 or 2 if any.
Wonderful talk, Dr. Ganesh Jeshwar, but I just have one question myself. So what is the cutoff for offering RIC and MAC, the age cutoff, like how do you choose for RIC and MAC in adults?
So one-liner answer is, all of us, most of us have various, practices.
Some people, some of the transplanters will keep 40, some 45, some 50, but most of us keep 50 as a cutoff for myeloablative versus RIG. But there are multiple factors deciding the choice between MAC versus RIGs. The most important is the disease condition at the remission status at the time of transplant, patient's age and comorbidity score. That all factors will decide, and as I showed in one of the landmark analysis, CI-BMT are more than 700 patients, all myeloablative, reduced toxicity and RIG, smart RIG conditioning, outcomes are almost equal.
So in Tata Memorial Hospital, the analysis was done, only they are doing RIG, not MAC to the adult transplants. They totally stopped MAC because of the toxicity, they retrospective data analysis. So yeah, so still
Yeah, that's what madam. So everybody has their own confidence with regard to their own choice of conditioning protocols. Professor Vikram Matthews has a phenomenal presentation yesterday. In fact, even CMC Vellore, high risk as well as standard AML, they have completely switched to flu-bu as their conditioning choice, and that paper with almost 300 plus patients has recently published 2022 blood reviews. So that's what I was trying to emphasize. It's not the, you cannot say one experience fits to all. Everybody has their own experiences and their own choices. Depending upon their experience and their own comfort with their own conditioning regimen choices, it varies. So nothing is right or wrong, and that has been proven. We have a literature evidence, CI-BMT or data set, all conditioning outcomes are with equal disease subsets, same disease subsets, outcomes are almost equal. It depends on your experience and your confidence with regard to one particular condition.
Any questions from audience?
Myeloma is supposed to be very radiosensitive tumor, and more so after completion of many cycles of chemotherapy, when they come ultimately for bone marrow transplantation. Probably that is the safest and best way to proceed, I feel.
Sir, in myeloma, most of us are tuned to do autologous transplant with standard melphalan 140 or 200. There was a paper, both almost equal outcomes long run, but we have a cutoff of 60 years for deciding the melphalan dose, but autologous transplant melphalan is the standard choice. Even for allogenic transplant, even though myeloma is radiosensitive, very rarely we do myeloma at allo transplant for very refractory disease, multiple relapse disease. Nowadays there are multiple more refined, better immunotherapy options like CAR-T, bispecifics are coming in. I am sure the allogenic transplant in myeloma will keep on declining, but even for plasma cell leukemias and high-risk myelomas with multiple lines of failures, we don't opt for radiation-based conditioning because of extremely high TRM, particularly in myeloma. Thank you, sir.
Questions? I think some questions.
Just how optimistic are you on chemotherapy-free conditioning regimens? That is something, a new concept that is coming up.
Absolutely. There are CD45 targeted radio-labeled drugs. Of course, initial experiences have been not so promising, but yes, they are on the rise, and there are trials going on. Not just CD45, there are other novel, conditionings targeting and stem cell niche conditioning targeting on the cancer stem cells, conditioning targeting on hematopoietic stem cells. That is on the rise, but the literature, still the data is in phase 2, phase 1, phase 2. Robust literature is evolving. Maybe future, probably chemo-free conditioning may be the future.
Thank you, sir.
Thank you.
If no more questions, we can proceed for the next session.
Thank
you, Dr. Ganesh. It's an excellent presentation. Our next topic is ATG in transplant. The speaker going to present is Dr. Rajiv De. Dr. Rajiv De is a hemato-oncologist and bone marrow transplant physician at Narayana Super Specialty Hospital, Kolkata, NH Kolkata. Over to you, Dr. Rajiv De.
Okay. Yeah, good morning, everybody. I'm also a professor in the Department of Hematology, NRS Medical College. Dr. Ganesh Jayashatwar, to all of you, is an par excellence hematologist and bone marrow transplant physician. But to me, he is not only my friend, we spent very difficult times during our DM residency, as all DM residents spend. So we still remember in Kolkata those difficult times. And so I'm very happy that today I am here for Dr. Ganesh. And that's why I didn't put much effort in preparing the slides, rather spending time with him. So my topic is ATG in transplant, but I don't have any knowledge in any transplant except hematopoietic stem cell transplant. So I will focus my topic on ATG in BMT. So what is ATG? We know that anti-thymocyte globulin is a polyclonal IgG component prepared and collected from the serum of various animals, rabbit, horse, goat, porcine. And the concept of ATG was initiated almost 100 years back. And the Russian immunologist Eli Metnikov got a Nobel Prize for this novel concept. Now the standard indications for ATG in hematology are severe aplastic anemia that we know, lower risk MDS, especially the hypoplastic MDS, as well as in BMT as a component of conditioning regimen to prevent the graft rejection is a standard practice in aplastic anemia conditioning, and prophylaxis for graft versus host disease, because now there is a rise in haplo and MUD, and so the role of ATG has become very important nowadays. Mechanism of action is mainly the complement-dependent lysis, and it causes opsonization and phagocytosis by the lymphocytes in the reticuloendothelial system, and there is apoptotic cell death. But the apoptotic cell death is not limited to the T cells only. It also causes induction of B cell apoptosis. It causes interference of the dendritic cell function and induction of Treg and NK T cells, which actually prevent the GVHD. So there are these two commonly available ATGs there, rabbit and horses. So although rabbits and horses are willing to provide ATG to us, yesterday from horses' mouth I came to know that nowadays the production of ATG is diminishing in our country because the cardiothoracic surgeons are not doing surgery of the thymus. So there is an inadequacy of thymus to produce ATG. So I don't know whether the information is true or wrong. So as per this latest British Journal of Hematology BCSH guideline for aplastic anemia, if it is less than 40, the standard treatment is sibling donor transplant if we have matched sibling. Otherwise, we need to give the ATG and triple drug therapy. If it is more than 40, the first line of treatment is ATG plus triple drug therapy. So ATG has got a very significant role in the management of aplastic anemia. While coming to BMT, part of conditioning regimen, as I mentioned, as well as GVHD prophylaxis. And so choice of conditioning, while choosing the transplant for aplastic anemia, it showed that the addition of ATG actually makes the differences in outcome, the probability of survival. And so ATG makes a difference. And here, if we add ATG, then irrespective of the different components of the conditioning regimen, the outcome are almost similar, but definitely we need to add fludarabine in the conditioning. So ATG is a very important part of the transplant conditioning. But GVHD, as Dr. Ganesh mentioned, that is the difficult and formidable barrier to the successful allogenic transplant. Your successful transplants can be jeopardized by if you have an uncontrolled GVHD. So the range ranging from 30 to 40% of acute GVHD, ranging to 60 to 78% of the chronic GVHD. And it is basically a donor T lymphocytes who are acting against the recipient cells. That is a fundamental of GVHD. And we need these three components. That is, the graft must contain an immunocompetent T cells, and the recipient must be properly immunocompromised so they can reject the graft, and there must be tissue injury by conditioning regimens. So these three components are required for our GVHD to happen. And T cells plays a very important, the activation of donor T cells are the main cause of GVHD. So we need to handle that T cells, and ATG plays a very important role in handling the T cells. So this is the pathophysiology of graft versus host disease, but whatever be the complicated pathophysiology, we can see that the main component is donor T cells. And that's why the role of ATG is there in preventing the acute graft-versus-host disease. The GVHD is acute GVHD. Conventional, it is up to 100 days of transplant, and chronic GVHD later on, but there is a significant overlap. Dr. Sharad is going to speak on GVHD. And there is different gradation of GVHD. This is the conventional gradation. Now there is a magic criteria. So the grade 3-4 GVHD are actually dangerous, and ATG plays a very significant role in reducing the grade 3-4 GVHD. And in all the transplants, mass sibling, MAD, and haplo, it has got a role now. So how we do the GVHD prophylaxis? One is the pharmacological agents, and then the T cell depletion. It can be in vivo or ex vivo T cell depletion. So acute GVHD causes directly associated with mortality. Chronic GVHD, it causes significant morbidity. And the range I mentioned from 30 to 70%. Although acute GVHD involves the skin, gut, and liver, the chronic GVHD can involve any organ, and the life can be miserable. So in this background, the role of ATG as a GVHD prophylaxis, because it is a polyclonal immunoglobulin, it suppresses the T cell function, and it has got a long half-life, and ATG also interacts with the transplanted donor T cells. It suppresses donor T cells and significantly reduces acute and chronic GVHD. And these randomized trial, this is a review and meta-analysis of randomized trial. So it showed that there is significant difference which has got an p-value of less than 0.001%. That is the regimens which contain ATG and not contain ATG has a significant reduction in acute and chronic GVHD. And this is a very good article, that is efficacy of ATG for allogenic hematopoiesis. It is a matched sibling donor. Systematic review and meta-analysis, 6 reviews are there, and it shows that in all the trials, the reduction in acute GVHD, it favors the ATG containing regimen. In chronic GVHD also, the data shows in favor of ATG. And there is not very significant differences as far as the overall survival, relapse, and disease-free survival is concerned, because the trials have a contradictory results to each other. So in the abstract, the conclusion is the incidence of acute and chronic GVHD was significantly lower in the ATG arm, but no significant differences was found regarding overall survival, the incidence of relapse and non-relapse mortality. And this is a much recent analysis published in 2021. It is also said that adding ATG to GVHD prophylaxis prevents acute and chronic GVHD. It is an updated meta-analysis. So it is proven over the years that it has got a significant role in reducing the GVHD. Then it is cases of multi-center study which showing the role of GVHD from unrelated donors. And this is a study population, 1:1 population. And again, it showed that in unrelated donor population, there is not significant differences in the overall survival, but there is reduction in the immunosuppression use in this population who have used ATG. So reduction in the immunosuppression means it is associated with less GVHD and better overall outcome and less chances of infections. So evidence of the role of PT-CY, because we know that PT-CY is now a standard GVHD prophylaxis for haplo, and the number of haplo is rising. And PT-CY, since its inception by Johns Hopkins protocol, and number of other studies, it's clearly shown that it is associated with a very good overall outcome in the haplo setting. But the disadvantage of PT-CY, there is a primary limitation of haplo BMT with PT-CY is delayed immune reconstitution. There is risk of donors for a secondary malignancies. So these things are there. So when we compared PT-CY with ATG, so we tried to see whether the PT-CY is better compared to ATG. So it showed that as far as overall survival, leukemia-free survival is concerned, the results are comparable, but graft and relapse-free survival are better with PT-CY compared to the ATG. So that's why PT-CY is now a standard practice for haplo and not ATG replace PT-CY. And there are other studies also which supported this concept. that ATG can achieve a better engraftment, PFS, and overall survival and lower incidence of NRM. Now, there is emerging evidence, so if both these are very important component in reducing GVHD, especially in the match unblated and haplo platform, so whether we can club these two. So, emerging evidences of combined rabbit ATG plus PT-CY for GVHD prevention. So, this study, this 1:1 randomization study. So, combining ATG plus PT-CY in the haplo setup. So, it is systemic effects due to different action of mechanism of action of ATG and PT-CY on T cell lymphocyte depletion, and it showed that ATG plus PT-CY combination significantly improved graft and relapse-free survival, GVHD and relapse-free survival in allogenic hematopoietic stem cell transplant for high-risk AML and MDS. So, this is now an interesting combination PT-CY plus ATG in managing haplo transplant. And now there is summary of evidences that use the combined regimen. Lot of studies are going on, and also there is publications, and it showed that overall survival, GRFS, acute and chronic GVHD, they are significantly low in PT-CY plus ATG combination. So, key takeaways for ATG and PT-CY that the GCSF and ATG regimen was initially employed for the haplo, but ATG can enhance the engraftment and diminish rejection by depletion of the recipient T cells and is widely used in various transplant types. PT-CY, again to overcome the HLA barrier in mismatch HSCT, the significant reduction in alloreactive caused by PT-CY base protocol raised concern regarding recurrence and graft failure. So, it is better to combine these two. Infusion of ATG, we know all these things, so I am not going into detail of what is the dose, because the dose varies from 15 milligram per kg to 4.5 milligram per kg. Now, we are reducing the dose because it reduces the chances of infections and better survival. So, overall the take home message is ATG plays a significant role in bone marrow transplant. It has been a part of conditioning regimen to prevent graft rejection for years, has a significant role in GVHD prophylaxis. In today's era of MARD and haplo, its role and scope is increasing, as in haplo setting there is a potent role of combining PT-CY plus ATG. Thank you. So, I am ready for questions.
Thank you, Dr. Rajiv Dey, for the overview of excellent sequencing and everything in transplant. So, any comments on our questions from the audience, please?
As far as the aplastic anemia immunosuppressive therapy is concerned, triple therapy or it is an ATG plus cyclosporine, the data shows that horse ATG has a better overall survival, better outcome compared to the rabbit ATG. But as far as a transplant setup is concerned, there is not much trial head-to-head horse versus rabbit in transplant setting. But in transplant setting, usual practice is to use a rabbit ATG. And so, either in aplastic anemia conditioning or in haplotransplant setting, we use rabbit ATG as a GVHD prophylaxis.
I think the question was about the availability of horse ATG, am I right?
Availability of horse ATG,
yeah,
okay.
Yeah. So, I think that was a problem some time back when, because Pfizer is the parent company which manufactures it, and they were given directives by US government during the COVID pandemic that they have to manufacture primarily, dedicate all those plants which are manufacturing ATG to for manufacturing the vaccine. So yes, there was a lag for almost 2 years or so, but I think the production has now initiated, and it's not that difficult to get it now.
But Pfizer one is not still available right now in India.
Okay, because I have stopped using horse ATG, so I'm not aware. But yes, there was a challenge. In
still only one brand is available in India.
The Indian ones.
Yeah. Till now. I think 4.5 milligram in over 2 to 3 days. It is a good practice, but you can extend up to 10 to 15. I prefer to use lower doses because of lower cost and lower chances of infections.
So my take on this is, when we tried to increase the dose of rabbit ATG in our haplo settings, the viral infections rates increased.
Yes.
So then we went back to 4.5 milligram per kg. The question to you is, can we further go on go down on the dose of ATG to 2.5?
Some people are using, but I am not an expert on particular on this question. I think Shotto or Gaurav can answer this question.
I think that's also pretty standard now. So there's especially for the malignant settings. So there's an NEJM paper where they have in AMLs and ALLs also they have documented 2.5 mg. So 1.25 into 2 days for adult AML. So that's also pretty sort of standard now. You can along with PT-CY.
Okay, so how many of us are actually using 2.5?
How long conventional physicians who don't have transplant facility should wait for conventional treatment before taking up the patient for transplant? Because if we delay long periods, the patient would land up with infections and then it would be very difficult to take up for transplant.
Yeah, completely agree. Basically, the flow chart is not like that. We will treat with the immunosuppressive therapy ATG, and if it fails, then we'll try for transplant. For aplastic anemia, if the age is less than 40, we first counsel for transplant. The outcome is best, more than 80%. And if we don't have a matched sibling donor, then we can counsel for ATG. But for ATG as a immunosuppressive therapy or for transplant, it has been seen that if from diagnosis to intervention is prolonged, preferably it is prolonged more than 1 month, the outcome is poor. And there is a few years back, there was a study, it said that for immunosuppressive therapy, that is ATG plus cyclosporine, the optimum days was 26 days. So if we do before that, the outcome is better, around 60 to 70%. But if we delay, the outcome is poor, both for immunosuppressive therapy as for this thing, transplant.
Any more questions?
Or 3 to 1?
It depends on for which we are using. If we, for this haplo setting with PT-CY or without PT-CY, it is better to place as close as possible day -1, -2, and -3. But for thalassemia transplant, it is better to use earlier because it is used for immunosuppressive therapy, not as a conditioning regimen. So, but for an haplo setting and when we want to prevent GVHD, it is better to use as close as possible, -1 to -3.
My understanding is that the proximal placement is mainly to enhance the engraftment, and the distal placement is for
to prevent
GVHD
GVHD.
prophylaxis. So, how do you place, I mean, in your regular practice? Like,
as a standard, in my practice, I use day -3, day -2, or day -3 to 1. Usually, I use for 2 days. And there is a concept of using post-infusion ATG on day +1, but usually I don't use that. I always use before infusion, day -1 to day -3.
If no questions, we'll proceed for the next presentation. Thanks,
thank
Dr.
you,
Rajiv,
thank you.
wonderful session. So there is a sequence change in this presentation. So next speaker is Dr. Gaurav Karya, who is going to present regarding CAR T-cell therapy, current status in India. Dr. Gaurav is a senior consultant and head Pediatric and Hematology Immunology Center, Bone Marrow Transplant at Apollo Hospital, Mumbai. Over to you, Dr. Gaurav. It's a very happening field. Everyone is, it's Delhi. Sorry, it's Delhi.
Thank you for this introduction. Yes, and I'm at Delhi, not Mumbai Apollo. Puneet is also here, who's my colleague at Mumbai Apollo. So thank you, Ganesh. He's not here, but thank you all. Thank you for having all of us here and giving us this wonderful opportunity to interact with our pediatric and medical oncology colleagues. And also, it gives us an opportunity to sort of come out of our monotonous routine and spend some time with our colleagues together, which is a big stress buster. So I've been asked to talk about CAR T-cell status in India. So just like other topic, it's a big topic, but I'll try to sort of summarize it in next 12 to 13 minutes. So these are my disclosures. So apart from my clinical affiliation, I also have a research affiliation. So I'm the founder and director of this entity, which is called as Celligent Therapeutics, which is working to come up with innovative cell and gene therapy solutions for various human diseases. Yeah, I have always try to start my talk with this very impressive saying by Marcus Aurelius, who was a Roman emperor who ruled between 161 to 180 AD. And he used to say that nothing has such a power to broaden the mind as the ability to investigate systematically and truly all that comes under thy observation in life. And I think we all sort of learn on a day-to-day basis as clinicians from our experiences and try to modify or use them to improve our practices for our future patients. Now, this is a quick overview of my presentation, so I'll briefly drill into the history, cover the basics of CAR T-cell therapy, evolution, CAR T-cell therapy workflow, status in India, challenges with the current monospecific second generation CARs, what is our approach, and then finally I would sum up and move on to the question answer session. Now, for any field to develop, there needs to be a person who has some out of the box thinking. So this is the person called as Dr. Zelig Eshar, who is an Israeli immunologist, and he was quite weird in his thinking, and he thought that probably if we can put some chimeric sort of markers on the T cells, they can be used just like antibodies to identify the foreign cells, whether they are cancer cells or infection cells, and subsequently they can kill those particular cancer cells or the pathogens. And he used this sort of approach to target the T lymphocytes to target the new HER2 expressing cells using the chimeric single chain Fv receptors. So this was a very impressive concept, but unfortunately it did not work because this lacked the component to effectively activate and proliferate the T cells in response to the stimuli. But this was a very, very interesting thought, where the T cells, which are the primary defense mechanism in our body, they were sort of used to tackle whether the infections or the cancers. Now this led to our better understanding and further evolution of the CAR T-cell therapy. So as our understanding of T-cell function improved, it became clear that essential components need to be added to enhance the functional and the potency of the CAR T-cell therapy. This led to the development of first generation CAR T-cell with an antigen binding domain connected by a hinge to a transmembrane domain, which is CD8 or CD28, and further it is further connected to an intracellular domain, which is CD3 zeta. So there is an extracellular domain, a transmembrane domain, and the intracellular domain. So this was the structure, basic structure of the first generation, which was more or less similar to how the T cells sort of our normal T cells act. So while the first generation of CAR T cells significantly improved the functionality, the desired anti-tumor effect were not fully observed, possibly due to the poor downstream signaling and also because of the poor proliferation status. So what happened subsequently is, to address this particular thing, people started adding another signaling domain, a co-stimulatory domain, which was either CD28 or 41BB, which led to further amplification and proliferation of the T cells, which led to further kill of tumor. So using this revolutionary approach, the first patient was sort of treated in 2012. So this was a young girl. Dr. Vikram Matthews also highlighted about Emily in his presentation yesterday. So she was a girl suffering from relapsed refractory B-cell ALL, refractory to all forms of therapy available at that point of time. So she was the first one to receive second generation CAR T-cell therapy at CHOP, Children's Hospital of Philadelphia, and rest, as we all know, is the history. It is almost 12 years since she has received the first infusion of CAR T-cell, and she still remains to be disease-free. This picture was shown yesterday also by Dr. Vikram. This was at her 10th anniversary of the CAR T-cell infusion. Subsequently, they formed an entity which is Emily Whitehead Foundation, which is quite actively working to come up with these innovative cost-effective, innovative cell-based therapies for various disorders. Now, this single infusion or this approach led to the open the floodgates for this particular approach to treat various malignancies, whether the liquid malignancies or solid malignancies. And this is how the graph of CAR T-cell therapy, global graph of CAR T-cell therapy looks like. So as we can see, majority of, and this was in 2021, the major focus is
Okay, so the major focus is in Europe, America, Canada, Australia, Israel, some activity in Singapore. But sadly, the representation from India is not there, but this was a graph in 2021, and we know, and we'll see in the subsequent slide, there is some activity which has started in our country, and I'll take you through what is the current status of CAR T-cell in our country. But before we move ahead, I would like to briefly take you through how this CAR T-cell therapy works. So these T-cells are the strongest foot soldiers to tackle either the cancer cell or a pathogen. And how do they do it? They do it using this T-cell receptor, and there is an intracellular switch. And once they are exposed to cancer, because we are talking about the CAR T-cell for cancers here, so once they are exposed, the cancer has a marker on its surface, so it identifies it and subsequently leads to activation of T-cells, which is a MHC based activation of T-cells. And after this activation, the tumor cell sort of kills, the T-cell kills this cancer cell. But these cancer cells, as we know, they are very smart. And the first thing they do is they lose their MHC, so they have the MHC independent expression of these markers, and that is how they escape the T-cell mediated killing. So what chimeric antigen receptor T-cell therapy does, so we put this additional identifier or a marker, which is called as a chimeric antigen receptor, on the surface of the natural T-cell and make it capable of re-identifying the cancer cell. So this is how it works. So we have an identifier which is reinserted. It again identify in an MHC independent manner. Okay, so it identifies the cancer cell and subsequently gets activated and kills this cancer cell. But this is not enough, because this is just killing one cancer cell, and there are millions and trillions of cancer cells. So another important aspect is that these T cells, after killing the cancer cell, should subsequently amplify and proliferate. And this is done by adding another co-stimulatory domain. So these subsequently they live as living drugs, and if the last analysis which was done on Emily Whitehead, after 12 years there are still chimeric antigen receptor T cell which are persisting in her body, which are leading to which are preventing the relapse of B cell cancer, aggressive B cell cancer in her body. So very, very revolutionary approach. So just like the CARs have evolved over a period of time, the chimeric antigen receptor T cell therapy has also evolved over a period of time. And as we can see, this is first generation, second generation, third generation of CAR. Similarly, this is how CAR T cell therapy has also evolved. So the first one, as I mentioned, can I have some water? First one had a extracellular domain, the transmembrane domain, and the intracellular signaling domain. But the second generation had, thank you. But in second generation, another co-stimulatory domain was added to augment the amplification and subsequently proliferation. And in the third generation, another co-stimulatory domain is added so that the persistence can be improved. Persistence can be further improved, because these are the mechanisms by which tumor tends to come back. So this is the timeline of CAR T-cell therapy after the initial work, which was in 1989, 1990. Subsequently, a lot has been done, and as I showed earlier also, there are almost 1,000 trials which are opened for CAR T-cell for different diseases, solid liquid malignancies, solid tumors, and even non-oncological diseases like various renal diseases and various cardiac diseases, autoimmune diseases, etc. So these are the drugs which have currently been FDA approved. So there are I think 3 or 4 on this list which have been added further. This is how the CAR T-cell workflow looks like. So if you have a patient who's suffering from a B-cell malignancy, we take out the T-cells, we sort them out using the Clinimex separator CD4, CD8, and then subsequently CAR transduction happens, which is done using a lentivirus. Okay, and this is the 4-plasmid model of lentivirus. So this is a self-inactivating virus. It does not have a tumorigenic potential. So this using this lentivirus, this chimeric antigen is introduced into the T cell, and subsequently the CAR T cell is further expanded, and then the patient who has to receive this undergoes some form of cytoreductive chemotherapy. These CAR cells are infused, and then subsequently these they start the cancer kill and subsequently persist in the body for a long time. So These are the diseases which have been dealt with using this approach. So liquid malignancies, a number of solid tumors. Rather, the first CAR T-cell approach for solid tumors has already got FDA approval for renal cell carcinoma, and a number of trials are going for immunological diseases as well as for cardiac diseases. Now, where do we stand as a country? So I might have missed one or two groups which are working, but this is what my understanding is. So there are 6 groups working on this approach. The first one, the pioneer, is IIT Mumbai and the ACTRIC group. Their construct, their design is indigenous, which is a 2nd generation monospecific CAR. They're using a manual platform for manufacturing of the CAR. They started their first clinical trial on 5th June 2021, and I think December they got the FDA, they got the approval from DCGI for commercialization. Immunil, they are using a 2nd generation monospecific CAR, which is imported from Spain, in-licensed. They are also running phase 1, phase 2 trial, and the approval is yet to come. Then there is Intas. I'm not sure about what is the current status of Intas, but they are also using the sort of lentigen from vector from lentigen and a construct from Miltenyi, and they are trying to do the phase 1 clinical trial. Same as the approach taken by CMC Vellore, which Dr. Matthews touched on yesterday. So that is the WellCART. He's already done phase 1 trial on academic level. Now they are moving on to phase 2, and subsequently they will apply for commercialization. Reddy is also phase 1 trial for BCMA CAR, not B cell malignancy, but BCMA CAR is phase 1 trial is already open. And then comes the Cellogen therapeutic. So our approach is to use the 3rd or 4th generation CAR T cell. This is an indigenous, it is not in-licensed, this is indigenously developed in our country. The vector also is developed in our country. We will be using the automated platform. The preclinical work has been completed. Now we are looking forward to initiate our phase 1 clinical trials. Now, what are the current challenges with the CAR? Antigen escape, in vitro persistence is not there. Antigen escape mediated relapses are there. CRS and ICANS, as we all know. Then insertional mutagenesis, but these 2 things have been addressed because insertional mutagenesis is not common there because these are 4 plasmid models of viruses, lentivirus. These are self-inactivating viruses that do not have a mutagenic potential. CRS and ICANS, with a better understanding of the disease and how it works, probably our approach to deal with CRS and ICANS has improved. But these 3 antigen escape mediated relapses, in vivo persistence, and most importantly the cost, these are 3 challenges which are still left with us to deal with. So how does it, a CAR T cell therapy, this cancer cell escapes this CAR T cell, so it can happen by antigen down regulation. Antigen escape can happen by antigen down regulation or antigen loss or a different lineage. So from CD19 it switches to CD20 or CD22. So a lineage switches there, and this is how the antigen escape mediated relapses can happen. So our thought was, can simultaneous targeting of multiple tumor associated antigens overcome the CD19 antigen escape based recurrence without compromising the anti-tumor efficacy and the persistence? And also, can combination of various co-stimulated domains increase the anti-tumor efficacy and also the persistence of CAR T cells? So these were the 2 basic questions with us. We wanted to increase the persistence and decrease the antigen escape mediated relapses. So our novel next generation CAR designs, so we worked on different designs using various co-stimulated domains and also targeting CD19, 20, 22 in different permutation and combinations. And we developed almost 40 constructs, out of which 10 were our constructs of interest and 30 were the test constructs. And if you look at the efficacy, so T cell activation, if we compare it with the CD19 monospecific 2nd generation CAR, the activation was much better, which is highlighted on the right side in the pink and green bar. Similarly, the tumor cell killing was more efficient as compared to the conventional CD19 monospecific 2nd generation CAR. The proliferation was also much better as compared to the CD19 CAR, and also the persistence, in vivo persistence was also much better as compared to just 2 or 3 more slides. So the in vivo persistence was also much better as compared to the conventional CAR. So our preclinical studies, we have done multiple set of experiences and mouse experiments, and we can very clearly see that the efficacy of the third generation CAR, which is shown on the right side, is much better than the existing second generation CAR, which is currently being used by different groups. So these are our knowledge partners in this journey. Many institutions have provided us phenomenal support, like IGIB, CSIR, IICB, Department of Biotechnology, and Jamia. And recently we got the much needed push when our industry partners, Netco Pharma, have invested some money. They've provided a series A funding to take this work forward, and this gives us a big push to initiate our clinical trial. And we hope to initiate it in the second or third quarter of this year. So with this, I would like to thank you all for a very, very patient listening, and I seek your blessings for the further journey as we move ahead. Thank you.
Thank you, Dr. Gaurav. Thanks for the insight regarding CAR-T as well as entrepreneurial aspect of the CAR-T as well. And to me, I just want to ask, second gen and third and fourth gen is quite different. So the immunogenicity, everything is quite different compared to second gen. So Delhi is a huge market for CAR-T, we know that. So usually they do market for Malaysian product, Israel product, and Indian product. So how do you place the indigenous product of Indian CAR-T compared to other? I mean, not with USA, but other.
So it's not only Delhi, the entire country has a huge potential. So we have almost 100,000 patients as per rough estimates of just B-cell malignancies, adult and pediatric put together. And as we all know that this modality is coming to the forefront. Presently it is being used as for relapsed refractory cases, but eventually there is a trial ongoing where this can be used as a frontline therapy. So the market is huge, but the prohibitory thing is the cost, which we need to work on. And I think making it indigenous is the first step to bring down the cost, because the license fee which you have to give to various companies like I think Reddy's have in-licensed the product from Pregene China. So a huge licensing fees goes there. So these are the prohibitory factors. So indigeneity, first of all, brings down the cost, and thus the application can be much wider.
Any inputs or comments from the audience?
I'm a pathologist. Can you throw a little light on what are the tests required and what are the issues involved if somebody wants to do the testing part?
Testing part for what, sir?
For CAR therapy. How do you,
So how do you identify a patient suitable candidate?
Before and after treatment, how is the response wise?
So before treatment, suppose I have a patient, I have a child who is suffering from B-cell ALL, has relapsed and is non-responsive to other agents. So it's a high-risk relapse. We have been able to bring the child in remission by giving one or other strategy. And then these are the patients who can actually be considered for CAR T-cell therapy. Now, an important aspect which I think you want to ask is that who's the right candidate? So if I have a patient who's having a disease burden of 30% cancer cells, okay, vis-a-vis a patient who has say 0.5, 0.6% cancer cell, who will be the better candidate? So obviously, the patient who has a high significant tumor load will have more chances of complications such as CRS and ICANS, vis-a-vis a patient who has less disease burden. And similarly, that will reciprocate into the long-term survival as well. So subsequently, post CAR infusion, to detect or check the efficacy or persistence of CAR, a surrogate marker is taken as B-cell aplasia. So you do your lymphocyte subsets, and if your CD19 subset is not there, that indirectly suggests that your CAR is still persisting.
Are there any big issues involved in this? Because people say it is very difficult to do the testing part and all that.
I think it will be
Or is it a very sensitive test that,
No, sir. Actually, you have to, these are specific tests because you have to identify your construct. So it's a flow-based assessment. You need to have the previous markers for that particular patient. And to check for B-cell aplasia, that's not difficult. So it's not that something can't be done. I mean, as a pathologist, you can very well do that. And there is a clear set of guidelines which is given to pathologists post-CAR infusion that these are the things, these are the tests we want to look for. But all of them can very easily be done in our country.
Thank you.
So there have been mortalities reported due to CAR T-cell therapy itself. Can you
So there is no modality which doesn't come with mortality with its own pros and cons. I mean, here we are dealing with a subset of patient which actually you don't deal with. They have an outcome of less than 10%, okay, or even 0%. So if at all you are able to, using this modality, you are able to provide an outcome of 50 to 60%, I think that's a commendable thing. So what will happen to another 30-40%? Obviously you lose them. So that's the downside. Unfortunately, it can't be reassured 100% that this modality is going to work.
HIV positive and
Exactly.
renal transplant patients can we take up?
So that's a very interesting thing. As I highlighted, there are CAR T-cell approaches coming for non-malignant disease also, and there's an ongoing trial for CAR T-cell therapy for HIV. So probably in a year or two, we'll have a CAR T-cell which can work on HIV as well.
Sir, do we need to reduce the disease burden before taking up the patient?
Exactly.
Or
So
can
just
it be
like your
used on
transplant, in transplant you prefer to take a patient in a MRD negative status, but here that's not the case. But the more you can reduce the disease burden, the better will be, and that's the logic of cytoreduction prior to giving CAR T-cell infusion.
So it cannot be used, it won't come in future as a frontline therapy, right?
Sorry? It will come out as a frontline therapy. Dr. Yadav was highlighting yesterday that there's already an ongoing trial, I think at CHOP or MD Anderson, where they have used CAR T-cell after the initial cytoreduction. So around day 15, day 20 of your induction, you bring down the disease burden and you just give CAR T-cell and then leave the child and follow up.
So today there's a controversy that maybe CAR T will replace a bone marrow transplant. In future, there is a controversy. Maybe in future.
That's the objective. That's the final goal.
Maybe
that's not a controversy. That's the final goal.
Maybe in future we may land up in where we talk about it replacing chemotherapy, intensive chemo also.
Yeah, absolutely. So, I mean, if you are avoiding in a child where you are just giving 15 days of chemotherapy and then infusing CAR and then just waiting and following up, so much of chemotherapy you avoided. So, I mean, it's definitely a more physiological approach. There's no doubt in it.
Oncology is going to get more and more simplified and.
Yeah, obviously, it's a learning curve. I mean, just like transplant, the outcomes were 2-3 decades back, they were way, way different as compared to what we are confident of offering nowadays. And I think same will happen to CAR T-cell therapy as well.
Thank you, sir.
So, Gaurav, excellent talk. I'll just
how do you monitor these patients clinically or laboratory-wise?
Both ways, sir.
Both ways.
Both ways.
And how
laboratory is very, very important.
And how often do you need to do this test?
So there is a set of markers. You have to do certain tests at day 14, day 28, day 90, and then 3 monthly and annually.
Okay. Yeah.
So I think the two things which are very, very important in CAR T cell is one is the initial expansion, proliferation to clear the cancer, and the bigger rise you get, maybe you better kill you will get. And the other is the persistence of these CAR T cells. Longer they persist, maybe the less chance of need for a bone marrow transplant or other therapies. The CAR T alone may be sufficient. And different CAR T cell products in the market have different sort of things. There are certain CAR T cells, like those for lymphoma in adults, they proliferate very fast,
but then
they
disappear
disappear and they're not persisting. And the CAR T cell, which is available for children in US, approved already, that persists longer, like the one Emily Whitehead got, and that's why transplant may be less required, still controversial. So regarding coming to dual CAR T cell, I think you are developing dual CAR T cell and you are developing a third generation. So do you feel that there is another new concept coming, the binding to the receptor? So if there is too quick binding, maybe the cytokine release and other toxicity will be more. So people are going towards that the binding may be little milder and maybe less things are there. So your comments on dual targeting, would it be more CRS, more toxicity, or you feel that that's not going to be a problem?
So I think that might be a problem because, sir, obviously you will be addressing more clones. So if you look at the sort of flow cytometry report, you'll have a CD19 component which is pretty strong. Then you'll have some cells which are CD19 weak and CD20 positive or CD22 positive. So obviously with the CD19 CAR, you are leaving that particular clone which is there weakly represented by CD19 positivity. So obviously with the bispecific CAR, you will be targeting them as well. So expected complications will be more, but then your preparedness will also be better. So you would like to prepare your patient in a much better way prior to taking them up for CAR T cell therapy. Having said that, it gives a lot of advantage in reducing the antigen escape mediated relapses, because that's a challenge. And if we look at the gist of ASH in 2023, the gist was this only, that the days for monospecific CARs are gone. We have to make it bispecific so that first of all we can reduce the relapses, which becomes a major challenge. So I mean, almost still 30 to 40% of the patients do relapse after this therapy. And as you highlighted, persistence, that is another big thing, loss of persistence. And for that, in our approach, we have added another co-stimulated domain which adds to the best persistence, which is the ICOS. So we tested 4 co-stimulated domains, 41BB, CD28, ICOS, OX40 in various permutation combination. 41BB ICOS works the best as far as the amplification, proliferation, and persistence is concerned.
Any more questions? Okay. Thanks, Dr. Gaur, for this interesting session. And we are proceeding with the next session. It's about MPN ASH update by Dr. Kishore Kumar. Dr. Kishore Kumar is an hemato-oncologist and bone marrow transplant physician at Yashoda Hospital, Chennai.
Thank you, chairpersons, and good afternoon. It was a good morning session for me. It has become good afternoon now, and great Gaurav, thanks to you. Yeah, no issues. So it's there, yeah. I won't be boring you much because already we are kind of bombarded with factors. And all of them have been presenting something which is quite broad, and I have been asked to present something which is very specific. ASH, for the people who are non-hematologists or students, it is American Society of Hematology meeting, the biggest conclave of hematologists across the world. So Dr. Ganesh has asked me to present this, and I had a doubt why specifically me to ASH. So I just thought, got a bit nostalgic. I think we'll be able to spot Dr. Ganesh here. So that was the time, this time ASH happened in San Diego. That's the Baja, California area, very near to Mexico. Ganesh was quite stressing me to have Mexican food in Mexico, and we ended up in a big trouble. So that was the story. Maybe that's the reason he wants me to present about ASH. And we were just talking about avoiding transplants, and that was Professor Goldman, the guy who did one of the earliest bone marrow transplants in chronic myeloid leukemia. After giving this award to me, 2 years later he died. No relations anyway. Maybe he was quite annoyed that he gave an award to me on CMLs. So I'll be very, very specific, just targeting myself into what this American Society of Hematology has offered in this spectrum of MPNs. When I say MPN, for the people out there, the biggest chunk of MPNs is chronic myeloid leukemia, which Puneet has taken us through what's happening there. So I'll be kind of targeting on the other MPNs which are non-CML, which for the students I should say it's myelofibrosis, polycythemia, and essential thrombocythemia. Why was this kind of division is because the poster boy of cancer chemotherapeutics or oral chemotherapy, imatinib, they just changed the classification of somebody who is BCR-ABL positive and who is kind of BCR-ABL negative, because BCR-ABL was very, very, very targeting and specific. So Goldman even said, the day, say Yashoda has got a beautiful BMT unit, I hope it flourishes, but the day when this BMT unit stops taking in cases that a non-transplant kind of a domain gets successful in different diseases like in CML, that is a real day of success of the hematology as a part of medicine, I should say. So that's where we are. In MPN, I don't think this non-transplant is still there. We are just trying to do that, but we are kind of yet to reach. So transplant role, I should say, is quite inversely proportional. A good numbers do need a transplant. Since there's an update from an international meeting and we don't have access to much of the drugs, I should be saying what I am doing so that I can avoid unnecessary questions at the end of the day. This is what we do in our center. Ours is basically a big transplant unit. We, in myelofibrosis, try to use ruxolitinib, sometimes even splenectomy, and then try pushing the patient for an allogenic transplant. That's the only one thing which works at the end of the day at this point in our country. Polycythemia, quite easy. Just do some phlebotomies. If needed, add some aspirin. If needed, some hydroxyurea. Very, very rarely, patients, when they're progressing, may need ruxolitinib or hypomethylating agents. ET is again relatively much easier to manage with some antiplatelets, and if at all needed, some hydroxyurea on and off. So secondary AML, when it kicks in, it makes our life easier, I should say, somewhat. Start with hypomethylating agents like azacitidine and then get on with an allograft. So I was looking into the amount of abstracts that are presented. Grossly, I was able to kind of understand this is what they are trying to do in MPNs. Basically, ruxolitinib, the JAK2 inhibitor, works quite well, but the well is not enough because MPNs are not only to do with JAK2 mutations. There are a multitude of mutations, CALR, MPN, a lot of things. There are triple negative MPNs also. So what they're trying to do here is trying to get the response to ruxolitinib much deeper by adding in some drugs to ruxolitinib, and they're trying to figure out the newer molecular pathways, and if at all somebody is on ruxolitinib and he fails on ruxolitinib, what to do in these cases where there is ruxolitinib failure. So these are all the very confusing names which are presented. I will just make a gist of it. Like the two big phase 3 trials which are presented were Manifest and Transform, which was about to do with something called as a BET inhibitor, which is pelabresib, and a BCL2 inhibitor, which is navitoclax. These are all again oral medications which can be added to ruxolitinib. And a lot of phase 1, phase 2 trial data, which I won't be discussing, were all on all this selinexor, this MDM2 inhibitor, and something called the telomerase inhibitor, imetelstat, even luspatercept, which is available in our country. So I should say this, I didn't wanted to show this Transform study because this has been done and presented by a person from this particular, I think his name is Naveen Pemaraju Garu. He has presented this data he's the son of the soil, I should say. Great study where he has kind of tried to add on this navitoclax to ruxolitinib in patients with treatment-naive myelofibrosis. Not much into the digging into the data, more down arrows are there, it means a better response. And we all know that there is more lies, and then comes statistics. So naturally the companies are going to take the data which is going to suit them more. So looking at the spleen volume response compared to just ruxolitinib alone and compared to addition of navitoclax, it was kind of double. So this is one of the first trials which have kind of proven to the fact that yes, navitoclax, a combination drug in addition to ruxolitinib, was trying to give us some deeper responses. Simultaneously, another Indian myelofibrosis mafia, I should say, who are there is Ranjit Rajpal, a good friend of us. He presented this data on BET2 inhibitor, which is called as pelabresib, in addition to ruxolitinib, which is again kind of an oral drug. This again shows nearly a similar response. The yellow one is the combination, which is pelabresib with ruxolitinib, and the spleen volume response they have shown it's kind of double compared to using ruxolitinib alone. So one thing what we worry is about safety of adding more and more newer drugs. Probably the safety profile was not that bad that the patient doesn't get into multiple issues when we do some combination therapies. So JAK2, if you really ask me, we all have ruxolitinib at this point, but the other 3 drugs which are in green, that is fedratinib, pacritinib and momelotinib, they're kind of already FDA approved. The last one in the kit is momelotinib, which just got its approval 2-3 months back. So now we have got a bigger spectrum of JAK2 inhibitors. To be more than hematologists, it is the dermatologists who have got a much bigger, wider spectrum of JAK2. They use it right and left in many diseases. But that doesn't have much relation to what we use in myelofibrosis. So this was a long, fedratinib is already approved, but still this ASH had a presentation of a wider and a longer follow-up data on this fedratinib trial, which proved that yes, even patients who are failing ruxolitinib, there's a small chance that we can get them on to something, a drug called as fedratinib. So ultimately they ended up doing an algorithm which is, I can't say it is very confusing, but it's quite simpler, that till on date, if a patient is fitting into the high risk category and is transplant eligible, transplant is yet to stay. So it's not that we are getting away with a transplant. But in case of transplant ineligibility or something, we are more and more getting into some specific targeting agents like your biggest problem, even if you find with ruxolitinib, is patients with a low platelet count. The company won't even allow them to get onto the compassionate basis use of ruxolitinib. So that has been taken care relatively by pacritinib, and the patients who have got more of anemia as an issue, momelotinib is something which we have got some, the basket has widened so that we can choose some drugs, especially in patients who are kind of failing to ruxolitinib. So next, moving on to polycythemia vera, nothing much I should say in polycythemia because it's not a disease which people who are treating will be knowing it on a relative basis till the time they get on to secondary myelofibrosis or leukemia. It's still a kind of easily manageable disease. But something called as rusfertide, hepcidin mimetic, is being tried upfront. The phase 1, phase 2 has started coming out, the trials, but it's too early to comment on. But still on date, if you see the cause of death in at least half of the patients, it is not progression or thrombosis, it is the primary disease by itself. So the Germans, following the footpaths of Hitler, I should say, they are almost always aggressive in anything. Even if you go to Hodgkin, they will be preferring Beercop rather than ABVD. So they have kind of tried to do a trial where kind of pushing. It's very logical to think because 95% cases of polycythemia have got JAK2 mutation. So it sounds very logical to use a JAK2 inhibitor upfront, but we all know practicing in our country, it may not be that pressing need, but still Germans have tried doing it. They want to really see, it's an ongoing trial, so it was an early data presentation. They say that the CR and PR at 6 months seems better when we use ruxolitinib upfront compared to hydroxyurea. But again, a controversial thing to debate on. But still, if somebody is going to ask tomorrow, can we use ruxolitinib upfront? Yes, there are trial data which is coming up even in polycythemia. ET is quite, as I said, it's all about platelets. Just give a dose of aspirin, 150 or 75, that's more than enough to kind of put your platelets down in action. So that is what we maximum do, but again there is a drug which kind of sounds quite interesting, a LSD inhibitor. So that is being tried in very, very early cases of ET, but this is the protocol they have kind of given. So nothing, a patient who has got a history of thrombosis and more than 60 and has got a JAK2, it is somewhere we may start using combination of Hydrea and aspirin, that's all. The patient who is in a very, very early phase or not that great a platelet count, then it's even aspirin alone is going to do. Naturally, when they progress on, it is going to be how we treat a secondary AML for that matter. So these are all general like disease specific drugs, but one drug which almost always fascinates us, not only into hematology but in Lycian setting, is use of interferon in all these conditions, even in CML for that matter. The first trial of imatinib was actually comparing imatinib with interferon for that matter. So this Dahlia trial was a long run trial where they, across MPNs except CML, they tried using interferon versus hydroxyurea, especially when it comes to pregnancy and all those things, people do had a tendency to switch on. Initial days it was looking like as if after beyond a certain point, like 5 years follow-up or something, the interferon arm was looking good when it comes to the molecular response of reducing the allele numbers of JAK2 burden. But on the other side, if you flip side, I should say, if you look at the amount of worsening of fibrosis, the yellow one is the interferon arm, the real worsening of fibrosis was kind of bad in the interferon arm compared to the hydroxyurea arm. Ultimately, this Dahlia trial data showed that there's not much of a difference between hydroxyurea and interferon. If you have got some specific contraindications of using hydroxyurea, you can prefer interferon, otherwise no use of going to a costlier affair rather than using hydroxyurea. So if I want to summarize what is being tried right now is they are trying to specify the JAK2 inhibition, they are going to go more and more deeper into JAK2 inhibition, and they are trying to add in some synergy to get some deeper responses, and actually the newer pathways which you haven't kind of heard of, I should say the BCL2, anything everywhere is what is being used. One drug which I was fascinated that it was not being up in the trials was venetoclax, because it is like an all-in-one drug that everybody uses in every condition. So I think few more days later, I think venetoclax also will come into the spectrum. And one thing they are kind of pushing is to early use of specific inhibitors in polycythemia vera. But if you really ask me, am I going to change the practice looking at the ASH trials? One thing I can't be changing because none of these drugs are available commercially or an affordable thing to me at this point in India. But at this point, I will still say my transplant and Jakavi is going to stay. And with polycythemia, it's a very debatable thing that we should be pushing in for a ruxolitinib, like a costlier drug like ruxolitinib early. So my hydroxyurea and phlebotomy and aspirin are going to stay. So you may be asking, indeed I wanted to present this, but anyway, Ganesh has asked me to present something different. So to present on ASH, what is the ethical consideration? I can present something on ASH. This was our data presentation in ASH this year about Hodgkin lymphoma, so totally unrelated to my actual talk. And this is a small, I can't say small, it's a 1,000-bedded hospital with a 10-bedded BMT unit and we have kind of completed around 500 transplants and still going on. So thank you very much. Any questions, I'll be happy to take. Yeah.
Thank you, Dr. Kishore, for this overview. Any questions or inputs from the audience to Dr. Kishore, please?
A lot of pediatric colleagues are there, so they've got nothing to do with myelofibrosis, I suppose. But this is one spectrum. I still feel CAR-T and all those things are quite far away. So the drug has been good. I just want to ask maybe to Uday and all people out here, what is the role of splenectomy? How many of you are kind of still getting on with splenectomy in myelofibrosis? Not? No.
None of us are doing it right now, sir. Unless patient is severely symptomatic with acute abdomen pain, like it's not touched by us.
That is.
Also, sir, ruxolitinib versus rho interferon, it's discussed always.
Yes.
So you presented that there is an increase in fibrosis with PEG interferon initiation.
Yes.
So what's your what's your thought regarding ruxo versus PEG interferon?
As I said, with the Dahlia trial data, I feel that ruxolitinib is much easier to do also. I think CMLs here we have used interferon, in T cells we have used interferon, but comparing the logistics and all those things, I think ruxolitinib is easier bet, I suppose, and we are going to shortly come in with generics also, so I think that's kind of going to stay.
If you have younger patients of myelofibrosis, instead of trying ruxolitinib, can we go for transplant directly?
Yes, sir. The ideal way is to do a transplant, sir, but to be more frank, many times the big spleen, whenever you put in the transplants, we have done around 20 transplants in myelofibrosis. But it's not that easier compared to the rest of AMLs or ALLs or whatever. The stickiness, I should say in a very layman word, the stickiness is not that great in myelofibrosis. So many times what happens, we start the process, but simultaneously start them on the JAK2 inhibitors. So at least a mild size reduction of the spleen goes a long way in having proper engraftment and all those things. So it's like a double way thing, sir. And one more thing, GVHD prophylaxis has already got the approval for ruxolitinib. So sometimes we do continue till the patient kind of gets better, gets into full remission. Yes, transplant is the ultimate goal. The preparation of the transplant, I think many times patient end up getting ruxolitinib.
If no more questions, we would like to proceed to other session. And thank you, Dr. Kishore, again, once again. So the next speaker is Dr. Saurav Bhave, who is going to speak regarding what's new in MDS. Dr. Saurav Bhave is a senior hematologist working in Mumbai.
This is forward. Huh?
Yes.
Yeah. So the talk given to me is what's new in MDS. Everybody has thanked Ganesh, but I will thank Raj Shekhar for the logistics he has provided, and I think Keyur Soni, the one who has managed the technical details of this conference along with Ganesh. So this is a very difficult topic. So whatever is new in the MDS is for those who have money and for the clinicians how to use the money wisely. Otherwise, we know that MDS is like cirrhosis, not much can be really done for most of the patients. So what's new in diagnosis, risk stratification, prognosis, treatment and response assessment. So this is how the trajectory of MDS has been. The upper part is the prognostic system and the down blue is the diagnostic system. So now we are into an era where you have two classifications, one by WHO and one by ICC. Then you have something called as IPSS-M, which is much more than IPSS-R. That M is for molecular. And we also have something called as CHRS. That means it is a clonal hematopoietic risk score. That means even before the disease has set in, you can score them to see whether how they evolve. So this is the classification difference between the two. There is nothing much which is really different between the two, but some entities are different between these two. So nowadays it has become difficult to remember the classification, which classification to stick to and which pathologies to approach, in which what they think as this patient fits into one box. But this is the current stratification. The MDS has done one important thing. If you see here, this is MDS H is hypocellular. Treatment may be a bit different. Then MDH F is fibrosis. Treatment may not be different, but the outcomes are poorer. And MDS with low blasts. So for hypocellular and fibrosis, something different can be tried in a particular subset of patients. Otherwise, more or less, both are similar. Now, this is the international MDS risk classification system. If you see across the last 20-30 years, now we are currently here. This is the MDS IPSS-M, the newest system. Now, this system has not really been used in the treatment algorithms till now. Whatever was used was mostly IPSS-R. This was the system which was used. And if you see, many of the clinical parameters in the IPSS-M have gone away, and you have added many more genes to it. So the classification has moved from clinical parameters a bit to more of a molecular parameter. That means if you have money, you have to do all these tests to really ascertain to which patient the patient belongs to which specific group, and accordingly suggest him a treatment approach. So we are becoming more and more personalized as we evolve. So these are the 16 main genes, and these are the 15 residual genes which are playing a role in MDS prognosis. Now if you see TP53 multi-hit, that means it has to be biallelic. I don't know how many labs will report a biallelic TP53. Not many labs may be able to report a biallelic TP53. More the TP53 mutation and more the copy, worse it is as compared to lesser TP53. So we can do what is called as a VAF, variable allele frequency. If the frequency is less, they may not really fall into a true high risk. So that we have to check with the pathology colleagues, are they able to report this multi-hit. Second, if SF3B1 5Q, that is association with 5Q, that is a good prognosis. And if you see SF3B1 alpha, that is associated with some different genes, so the prognosis is not that good. And the 15 residual genes, and then you have 6 groups across. So that is how it is now evolving, that we have to do all these things in able to understand what to do with the patient. And what has really changed is that some low risk groups have becoming very low, some high have becoming less high, some have become more high. But more or less, if you see, more or less it remains the same. So with the change in classification, almost half of the patients were re-stratified. Out of that, 74 out of the re-stratified moved from a lower to a higher group, and 26 from a higher to a lower group. So that means those who move from lower to higher, you have to more closely follow them up and offer them a treatment plan. This is the patient survival basis on both IPSS-R and IPSS-M. And if you see, the very low risk groups are really doing well as compared to high. Now if you see between the two risk stratifications, the high and the very high are more or less behaving the same. So that has really not made a difference in the outcome of patient. So what is important for us? A good quality bone marrow aspirate is most important, and a biopsy, which is a must. Without that, you cannot diagnose a good myelodysplastic syndrome. Second, you have to do a 20 metaphase cytogenetics. 2 metaphase, 8 metaphase, 10 metaphase report which is incomplete is not going to solve the problem. And FISH cannot replace that completely. Even though you may do it as a complementary, it is not a replacement. Now flow cytometry may not be able to diagnose an MDS unless there is very minimal dysplasia. So that flow is probably a supplementary test, not a mandatory test, unless in special situations where you think that there are blasts. And now molecular markers are a must, and you have to do the entire panel to look for it. Now the therapy is selected on what? Risk stratification, transfusion needs, percentage of bone marrow blasts, the karyotype, mutations, age and comorbidities, potential for a transplant, and prior exposure to HMA. So you have 8 characters to decide on how and what to give, and on top of it, cost. And when cost comes, nothing is important. So when cost comes, transfusion probably is the best way to keep the disease going on for some period of time. The goals of therapy probably remain the same. In lower risk, decrease transfusion needs, reduce transformation to higher risk disease or AML, and improve survival. That means, can you alter the natural history of disease in low risk and delay the progression to higher risk or AML? In higher risk, anyways you cannot do all that, you have to just prolong the survival. So this is low risk treatment with erythropoietin stimulating agent. This is available, so not much of a difference. You can read it in the system, but this remains one of the good treatments. But you have to give it for a good period of time with a good dose to say it is not working. Now some have tried GCSF combining with erythropoietin, and there are some studies to say that it works better than a single agent if that single agent is not working enough. Iron overload has implications in outcome, both non-transplant and transplant. If you are able to transplant patient, try to get down the iron low as possible, but don't wait for it to come down, just like we wait for thalassemia. Thalassemia, we can wait for a little bit, iron to come down and then transplant. Here we may not have that time gap to wait, and all currently available iron chelators can be used. Now this is the different treatment strategies for various diseases. It's a pretty busy slide, so it is available. So one new addition is luspatercept. MDS RS cost is 75,000 rupees every 3 weeks subcutaneously. For a specific group of patients it can be tried, yes. And there are trials when you can use luspatercept even in non-indicated MDS condition, but it is still not approved. Rest all we more or less know. The targeted therapies are only in trial areas, not as approved as yet. So in high risk MDS, azacitidine still remains the king. Nobody is able to beat it till now, but it still remains. So these are all the clinical trials combining AZA with something, and to date not really any major improvement has occurred whenever you combine AZA with something. There was some hope with venetoclax, but the toxicity was pretty high in MDS as compared to AML. Magrolimab was somehow withdrawn from this specific indication. So we have to still wait for more mature and phase 3 data to say whether you can add something to AZA currently in high risk MDS. These are the novel targets, and the biology has really fascinating. So this is apoptosis. One, you can use a BCL2 inhibitor, which is anti-apoptotic agent, and second is a RARA agonist, where you activate and differentiate the genes and allow apoptosis by combining it with azacitidine. This is one promising agent. And second, you have to use immunological as well as cellular agents to tackle the blast as well as the MDS cell by using macrophages through magrolimab and by engaging the T cells through sabatolimab. So these are two agents which are currently in trial mode, but probably are offering hope. This was one ASCERTON study, phase 3, where all oral combination instead of injectable or IV decitabine was tried, and the criteria was intermediate to high risk MDS and CMML or oral drugs, and it was non-inferior to the subcute or IV decitabine. So people who don't want decitabine are not able to take it because of the hospital which is very far away. All oral can be tried. Allogenic transplant, there was data in ASH 2023 where they used PT-CY compared to ATG in unrelated donors for MDS. It is a retrospective study by the EBMT working group, and it says that probably PT-CY may be better instead of ATG in this setting, and it can be a valid option when you don't want to use ATG for whatever reasons. Now, how you proceed for a patient of transplant? You have to define the risk stratification. In low risk also there is a scope for transplant if you have severe cytopenias, poor cytogenetics or fibrosis, or age and index prefers a transplant. So suitable patient selection is must. Try to reduce the mutational burden as low as possible. They say that TP53 preferably the VAV should be below 5 for the best outcome. Then you condition probably with RIC because many of them are elderly. Then you do a transplant with whichever donor is early available. You may not wait for a mud donor if you have an haplo. Also consider PT-CY for haplo, PT-CY for mud and MRD as well. And you can use maintenance therapy in the domain of clinical study. And if you are relapsing, IS reduction or a DLI, which is standard like any ML. So the main aim is to select the patient properly and early. So this is if you have a lower risk MDS, but he can go to higher risk MDS if you have fibrosis, if you have a bad cytogenetics and a bad mutational profile. So such patients you have to start looking for a HLA donor and counseling right from day one. Closely follow them up, maybe monthly counts, and check whether everything is all right. If they have hypocellular MDS in specific younger patients, IST may be tried. It may work like aplastic anemia, it works. Transfusion support, luspatercept, len, and allogenic transplant. And if there is any clinical study anywhere available, please try to enroll a patient who is not able to afford any of these things or you are not able to do it in a proper way. Response assessment, the response assessment has changed. It is very tough to understand what they mean, but it has changed. So ask the pathologist that it has changed. Please look at a criteria which is now fitting into the latest International Working Group 2023 high risk MDS criteria for response assessments. Now can we alter the natural history of disease? There are CHIP clinics which are in the Western world, and it's thought that they have to be followed up with peripheral blood every 6 monthly based on degree of cytopenia and the type of mutation. That is not only important for MDS, but also for the patients, that these patients may have an increased cardiovascular risk, and it is thought that such patients may also need a treatment for their cardiac disease. So for that, CHIP clinics you may establish, monitor them very frequently, and at the earliest progression offer them the best available treatment. Second is, there was a study which randomized 60 patients who were transfusion independent with 5q deletion to 5 mg len or a placebo. If you are transfusion independent and 5q, you may continue to observe. Here they wanted to give len versus observation, and it was thought that the delay to transfusion need was lesser in len arm as compared to placebo arm. That means len tried to alter natural history of disease without causing any major mutational or karyotypic change in the patient. It is one of the first examples where early intervention in MDS looks to be successful. So what we can do, these are last 2-3 slides. Detailed diagnostic and prognostic tests should be done in an affordable only patient. If you don't have affordable patient, don't do any tests. Just collect the basic material and leave him alone. Assess the true risk as per the latest guidelines. Low risk supportive care, but keep a close watch if he has high risk markers. High risk MDS, ASA still looks to be the best. allo-HCT still remains the only cure, but select patient, and in certain high risk MDS, even allo may not do as well, especially TP53 and complex karyotype. So the counseling has to be perfect. Now border between low and higher risk MDS is becoming stringent. More and more of personalized risk assessment is there. You have to gather knowledge from several scoring systems. You may say that IPSS may not be the only available. You have to go back to IPSS-R or maybe backward even before that. In-depth analysis of individual symptoms is a must, and probably discuss at multi-professional conferences for an appropriate treatment plan. So today don't lose hope, tomorrow it will go into metamorphosis. This is not only growth. From a caterpillar to butterfly, there is a metamorphosis. Everything changes, functionality, look, everything changes. So everything might change in next 20 years, so we are still hopeful. Thank you.
Thank you, Saurav, for the excellent talk. Any comments, questions from audience, please?
If serum erythropoietin is normal, will erythropoietin injections work?
There is a cutoff of 500, so to speak. So to speak. But sometimes you may give, sir. If there is nothing available, there is no harm unless patient has a risk of thrombosis or patient has hypertension which may worsen with erythropoietin. So sometimes we can even try in a higher level of erythropoietin to try erythropoietin, but the cutoff for MDS is 500.
Oral aceclidine.
It's subcutaneous.
Now oral also has.
Most of the trials are on injectable ASA. Oral ASA currently for AML who are not able to take the further intensive chemotherapy and are in CR after first induction. But you can try. People try. There is nothing wrong if there is patient understand that oral ASA may not be equivalent to subcute ASA, he may definitely take.
I have one question, sir. Is the transplant outcomes are different based on the cytogenetics? The 5q deletion, is it really varied outcomes will be there with the transplant instead of doing transplant?
Is more the more complex you go and more TP53 you have. Risk of relapses are lesser for low risk. It's like 821. They relapse after transplant less likely as compared to a complex.
Just about nice talk. With MDS, with MPN, with the blast, and there are, myeloproliferative picture with dysplasia, how do you manage?
Azacitidine, probably allogeneic transplant after that.
Sir, congestive cardiac failure patients with ejection fraction low, what is the optimal hemoglobin level you would like to maintain, sir?
9 to 10. Cardiac, 9 to 10. Cardiac patients, especially. But iron overload may be significant then, and iron chelation has to be used.
Thank you, sir. And there is some sequence changes in the presentation. Next speaker is Dr. Ankita Jaiswal, who is going to speak regarding role of NGS panel in hematology. Dr. Ankita is a lead hematology and flow cytometry consultant at National Reference Laboratory of Core Diagnostics, Gurugram. Yeah, over to you, Dr. Ankita.
Where is your system kept? Okay. A very good afternoon to all, and I thank the organizers for having me over. It has been a lot of learning, I'm a hematopathologist, so it's always good to be amongst all my clinicians and to see their perspective towards what we are actually doing in the labs. So the topic for me is role of NGS in hematology. Now, times have changed, it's an evolving era, and we had PCRs, MLPAs, which then moved on to Sanger sequencing, and now we are coming to an era of next generation sequencing. Next generation sequencing is also known as massively parallel sequencing or secondary sequencing. So what actually it is all about? What we do is that the millions of shots of DNA sequences are immobilized on a surface, then they're amplified and sequenced. And all this data that is generated is actually not in a readable format. And hence we need people. We need a bioinformatician, we need a hematopathologist to make sense out of all that data. So then this is all mapped to a human reference genome and analyzed. We have various types of NGS techniques already available: whole genome, exome, transcriptome, methylome, histone-associated genome. If I'll talk briefly about it, whole genome means, if we remember back to our 11th, 12th biotechnology and biology days, that every DNA had exons, which was the coding part, and introns, which was the non-coding part. And it is the introns which makes the bulk. It is approximately the 95%, which is the non-coding part. So either you could sequence the whole genome, Of course, you could pick up many more mutations, but at the end of the day, it's a lot of wastage that is going to happen. So then came in the concept of exome, because here only the exonic DNA is being, the coding part is being amplified and sequenced, and therefore it is more cost effective as well and time effective. Today we have various platforms for doing NGS. So here are Thermo Fisher's Ion Torrent S5 and S5 Plus. Genexus is the next go, where there is a lot of automation. So here you can even keep the DNA scraps and everything else will happen in an automated way. So this is the most evolving platform, and Illumina has been there since quite a lot of time. So if I briefly break up the whole workflow of NGS and keep it very simple, you give us a bone marrow or peripheral blood sample or a fresh frozen paraffin embedded block. From there, we go on to do DNA and RNA extraction. Then there is a thing called library preparation. So basically, after that, we sequence that library, we do data analysis, and then generate a meaningful report. Because like any other modality in a pathology lab, you will have some noise. So you can't just take it and make an AI report. You have to make sense out of all the data that has come. So if we look at what is done, either you can send, which I'm just cutting myself short and saying that as a hematopathologist, I will say always choose one lab from end to end to take care of your patient. You will always get better, fantastic results. So right from as simple as CBC, to peripheral blood smear, to bone marrow aspirate, bone marrow biopsy, flow cytometry. That's the basics that we do. And if we arrive at a diagnosis of MPN, MDS, acute leukemia, it is from there we go on to the more specialized techniques like karyotyping, FISH, RT-PCR, NGS. And if you've ordered an NGS, after the evaluation of the entire information, we go for the procedure of DNA and RNA extraction. So the first quality check happens after this extraction. It can pass the quantity and quality, or it can fail. If it fails, then you have to release a TNP report, and we will speak to the clinician and let them know that, okay, we couldn't come with an answer. If it passes, then we go on for the first step, that is the library preparation. Again, a quantity and quality check has to occur after the library preparation, which then passes. Then you go for the NGS loading, the sequencing happens, and again, after this data also, an analysis has to occur, whether it has failed or passed. That means that whether the number of reads that we are seeing are adequate, or there's a lot of raw data that happens behind an NGS report. So the read, the total coverage, that all has to be seen before we actually see that whether we've got all the mutations that we were expecting or not. So if it passes, you get a report. If it doesn't, then again there is a run quality fail. We may here, before releasing a TNP or a non-diagnostic report, actually attempt a rerun. So that is what we do. We give an interim call to the clinician and tell them that, okay, the run has not passed. Because if you realize, you may get upset as a clinician, or the patient may get upset because it's been 2 weeks and you've been waiting for the report. But it is this point that we come to know. Everything has been automated. It is only now we come to know, okay, the DNA run has failed or pass, or the RNA run has failed or pass, and then we really attempt a rerun, because we do have more DNA or RNA if the sample is available with us. So this is the basic out. So what do we all see? So in DNA, it's the hotspots and the indels. Indels are your insertions and deletions. In RNA, we look at the fusions and translocations. So I think with all the talks, we have always covered some part of NGS, because today, if you look at the WHO 2022, everything has been actually simplified. I feel it's a simplification over all the previous WHOs, because all the myeloid and lymphoid malignancies, they have basically put into 2 categories. One is with defining genetic abnormalities, and one is morphologically defined. A pathologist can actually go either of the 2 ways. If we are in a resource poor setting, we can limit ourselves to morphology and go ahead. And if we are in a resource rich setting, then we can actually go for the entire workup of the patient. So now genetically defined, we see that in myeloid malignancies, as just Doxap showed, that SF3B1 and biallelic TP53 are now the part of the defining criteria. So apart from that, TET2, ASXL1, SRSF2, DNMT3A, UTAF1, EZRIN2, ZRSR2, STAC2, IDH12, CBL, NRAS, BCOR, all of them have a prognostic implication. So basically, if I summarize the role, it is either diagnostic or prognostic. And when it comes to diagnostic, many of them are available on other modalities like RT-PCR. So then the question may arise, why NGS? Why spend such a lot of money? I'll be showing you with examples of 1 or 2 case studies. Now, we know that the ICC and the WHO 2020 actually has put up a classification of MDS/AML, and where the blast cutoff could be 10%, and if the 8 defining mutations are available, we could actually straight away go for a more aggressive therapeutic approach. In MPNs, we always could do JAK2, CALR, MPL, the driver mutations in the non-BCR ABL1 settings, but then the CSF3R, which is a marker for chronic neutrophilic leukemia, or ASXL1, DNMT3A, which are prognostic, they really help. Again, in cases of eosinophilia, one needs to work up for PDGFR-A, PDGFR-B, FGFR1, JAK2 rearrangements, and then NGS comes in handy. MDS MPNs again is a big question, a big diagnostic challenge usually, and it is these mutations when they come up, TET2, SRSF2, ASXL1, SETBP1, they really help and allow you for a proper treatment. We have seen that 40% of AML patients actually have normal karyotype, and their mutations like NPM1 and SEPA actually provide a favorable prognosis, and FLT3, DNMT3A, ASXL1 have poor prognostic. And IDH1 and 2 are two mutations where actually what are their partner mutations will allow you to show that whether they are going to make it a favorable prognosis or not. So when IDH comes in with NPM1, it's still a favorable prognosis. But when it comes in with DNMT3A, then it's a poor prognostic marker. So that is why the NGS is required, because you are not targeting a single gene. You are not left with half the information. You have the entire set. And now we will see with time that MRD monitoring will be more and more done by NGS, and VAFs of 0.1% will be interpreted. And comprehensive myeloid panels are, I think, the way to go forward. NGS has already been in use to diagnose all the mutations of hemoglobinopathies and thalassemias, bone marrow failure syndromes, membranopathies and enzymopathies, and very important for the clonality of lymphoproliferative disorders. The IgA gene rearrangement and the TCR gene rearrangement, they really come in handy. So if you look at various mutations in myeloid malignancies, it's a disease overlap, AML, MDS, MPN and MDS-MPN. And all these mutations could broadly be put into subcategories. So they are either transcription associated, splicing mutations, epigenetic genes, cohesion complex genes, cell cycle genes, or cell signaling genes. And actually, apart from your few diagnostic mutations, most of the mutations can actually be seen in any of these myeloid neoplasms. So it is the requirement of a hematopathologist to sit with your molecular scientist and interpret the clinical presentation of the patient, all the previously done reports, and then give the clinical relevance of that particular mutation, which may change as per the clinical scenario. So this is again just highlighting the fact that you may have gain of function mutations or loss of function mutations, and here is just the name of various myeloid neoplasms, and it is the list of genes, and you can see it is present in one or more of the myeloid neoplasms. So this was one of the case studies where we had the sample right from scratch, and he was a 62-year-old female presenting with easy bruising and fatigue. The CBC was hemoglobin 8.6, TLC 35,000 and platelet of 30,000. The bone marrow morphology was acute leukemia, and there were no ORRODs, but yet looking at the morphology, it could be myeloid. When we attempted a flow cytometry, AML with monocytic differentiation was made with 50% monoblasts. and it was positive for the monocytic markers like CD64, CD11C, CD4. And karyotyping in fish were normal. I told you 40% AMLs have normal karyotype. And we did NGS. So we got tier 1 variants which were positive for NPM1 with a VAF of 45.5%, FLT3 a VAF of 32%, and DNMT3A a VAF of 45.2%. So now NPM1 in isolation is a good prognostic. When it comes with FLT3, it's an intermediate risk. But because of NGS and the positivity for DNMT3A, we could put it as a poor prognostic AML. In case study 2, this was a 75-year-old male having a huge spleen, CBC of 11, TLC 25,000, platelet count of 5.5 lakh, and the cytogenetics was abnormal, 46XY inversion 12. When we did a bone marrow biopsy, it was classical of primary myelofibrosis. And the mutational analysis showed again tier 1 variants of JAK2 positivity, NRAS positivity with 2 subclones, 2 different types of clones, and ASXL1. So this, if we would have done just an MPN reflex panel of JAK2, CALR, MPL, we would have missed on the NRAS and the ASXL1. Both are basically illustrating that there is a very complex clonal structure underlying this disease, and it is even poorer in prognosis. So if I sum up, what are the advantages of this technique as a whole? Variants are reported together at the same time on a single report, and your interpretation will take into account all these variants. Then the cost would be less as compared to a single gene testing. You provide information on the subclonal structure of the particular disease. And maybe today we do not have a lot of information to do what to do with that NGS report, but times are evolving, and this particular field itself is a very evolving field. And as we'll grow in time, WHO has put one category in most of the diseases where you are just dumping the genetic mutations which you don't know what really to do with. And I think reanalysis of data after 5 years would give us a lot more information. It allows you to detect variants which have targeted therapies available, and it also allows you to detect novel mutations which we may not know of as of now. The basic problem clinicians face is what to do with variants of unknown significance, and some information is not currently available with what mutation implications are. And in US, there's a lot of reimbursement issue yet to be sorted out. So I'll just summarize what is the HGVS nomenclature. This is how a gene comes out in our reporters. So the first part, the NM so-and-so, is the reference sequence. The second part is the coding DNA, what exact position, what nucleotide change. So again, the DNA was just ATGC, and the RNA was just AUCG. It meant nothing. It is the arrangement from where we start. Just a few slides. And then it is the last, which is the protein change. So from this, the real information comes. And we have on reports the ACMG and AMP classification. So ACMG is a 5-tier classification, which is pathogenic, likely pathogenic. Yes, I'll be finishing it. VUS, likely benign and benign. And AMP is tier 1, 2, 3, 4, which is strong clinical, potential clinical, unknown, and benign. So in core diagnostic reports, because I'm a part of their team, how a report looks like, the first page has your mutations, drugs available, and from where the clinical trials have been done. The second page elaborates about the mutation and tells you the ACMG and the AMP classification. Page 3 elaborates the clinical trial. The page 4 tells you in detail about the gene and its clinical relevance. And the last tells you about the drugs and the approval and the theory behind that. So this is our panel, and I thank each one of you for the patient hearing. And I especially thank my team and my colleagues who are handling work when I am out at conferences. So I thank everyone.
Thanks, Ankita, for simplifying the topic, which is really difficult for all clinicians. Any questions? Quickly, please. We are running short of time. Quickly, 2 questions.
Library, if you will look at the chip, there is a chip in NGS. We don't run like tubes for CBC we run, right? And every machine has some input. So in flow, we are processing again putting tubes. In NGS, we put chips. And on those chips, the DNA and RNA extracted is placed and for multiple samples. And that process is called library preparation.
So that is standardized, right? It is based on an individual patient, or the chips are common for, you know, you?
No. Every chip can have a particular volume of DNA, RNA. So a chip generates around, say, X number of reads. So if you have set in your lab that how many reads you want per patient, then the total reads divided by the number of reads, that many samples you can load on that chip. So it can be individualized depending on the machine that you are using, the chip you are using, and your own practices.
Okay.
So as of now, different labs are proposing different costs, but it goes between 10 to 15K starting range to as high as 30, 40K.
Thank you. You have raised a pertinent question of not being reimbursed by insurance and other things. So we can ask our Ganesh to write up a note to our government to include this as a reimbursement through insurance and other means.
Yes,
because
absolutely.
we had a good elaboration of various national speakers and national faculty. We can give a write-up to government regarding inclusion of reimbursement facility for these investigations also. Thank you.
Thank you.
If no more questions, we'll proceed for the, sorry.
In India also there are issues, but US,
In
yes.
India, I think we give it. If the hospital puts it in the bill, it is reimbursed.
In India, it is still easier. In US, because everything from scratch to finish
Yeah,
happens
I think
directly through the payers, there is a bigger problem. Yes.
And yeah.
If no more questions, we'll proceed for the next session. Thank you, Ankita, once again. Our next session is AML in 2024. The speaker is Dr. Uday Kulkarni. Dr. Uday Kulkarni is a hematologist professor at CMC Vellore. Over to Dr. Uday.
Okay. Thank you so much, and really grateful for the hospitality here. I would really thank Dr. Ganesh for this exciting academic feast. So without further ado, the job at hand is to discuss acute myeloid leukemia management in 2024 in the next 13 minutes. So just to put things into context, access to care in AML is a problem. And if you look at this publication way back in 2015 from our center, only about 30% patients were treated. So that's the problem with access in AML. Fortunately, now with advent of azacitidine venetoclax, more patients are treated, but still access remains a challenge. And this is primarily because of the non-biological risk factors. And over the next 12 minutes, I'm not going to discuss the non-biological risk factors. We'll stick to biological risk factors in AML. So the first step when we diagnose acute myeloid leukemia is diagnostic testing. So we do cytogenetics, we do next generation sequencing, as was very nicely alluded by the previous speaker. Only one thing that I would like to highlight from a clinician's perspective here is that FLT3 ITD should be done by PCR and not by NGS, because if you have long ITDs, they are missed by NGS. So one needs to understand the limitations of NGS as well. So when we diagnose a patient with acute myeloid leukemia, this next generation sequencing, cytogenetics, and screening for gene rearrangements is done, and there is a panel which is recommended by the ELN. So the next step is, once we have diagnosed and we have done the diagnostic testing, is classifying AML. And as was alluded to in the previous talk as well, you have the ELN 2022 has the ICC classification, which is hierarchical. So you have AML defining recurrent genetic abnormalities, TP53 mutated AML, then whole set of mutations which define myelodysplasia related changes, karyotypic abnormalities and NOS, and there are diagnostic qualifiers as well. I am not going into this Pandora's box of comparison of WHO 2022 versus ICC, but just be aware that there are, what you call as AML with MDS related change, there are quite a lot of nuances between them. There are certain abnormalities which are called as MDS related by the ICC and not by the WHO, and by the WHO and not by the ICC. But essentially, not much of change in terms of, when you are managing patients clinically. Another point is the BZIP in-frame CEBP, and we'll come to that subsequently why this is clinically important, difference between the WHO and the ICC. The next step is risk stratification, and this is the current ELN 2022 risk stratification that we use in AML. Again, not going into granular details of 2022 versus 2017, but FLT3 ITD is essentially always intermediate risk now. BZIP in-frame mutated CEBP is favorable risk and not double mutated or single mutated as previously. Even the adverse risk categorization is a whole lot of changes in the 2022 ELN, and they have defined complex karyotype more clearly with exclusion of 3 or more trisomies without structural abnormalities are not complex karyotype. So these are the differences between 2022 ELN versus 2017. Now, as we discussed why the change from biallelic CEBPA to BZIP in-frame, and which is essentially BZIP indel, because this is large data set from Germany essentially showing that you have only the BZIP indel. If the CEBPA mutation is there in the BZIP indel, it's an indel type of mutation, then you have good prognosis. Rest all mutations do not portend a favorable prognosis. So it's important to understand this when we are reading reports in the clinic. Now, can we wait for these test results before we start therapy? And this is again from a large data set from Germany essentially showing that time from diagnosis to treatment doesn't alter the prognosis. So you can potentially wait for all these reports to come before you decide therapy. And we'll come to that why this is important. The next thing is some of these patients with acute myeloid leukemia, we need to do germline testing. We need to be aware of this. If you have a personal history of 2 or more cancers, if you have a personal history of a hematopoietic malignancy and family history of another hematopoietic malignancy earlier than average age at diagnosis of the malignancy, or deleterious gene variant, that could be germline. So if you identify a CEBPA which is known to be germline, it's important to do germline testing, and the germline testing should be done on non-hematopoietic tissue like the cultured skin fibroblasts. Now, why is germline testing important? Just to illustrate that, if you have somatic CEBPA, we all know that indel CEBPA has a very favorable outcome. They will respond very well to therapy. If you don't test for germline in these patients, they are at risk for developing new primary AML subsequently, and potentially one would transplant these patients. That's why it's important to know when to do germline testing in AML. The next step, once we have done the risk stratification and decided on germline testing, is assessment of fitness. This is data from the Hematology Cancer Consortium, a good effort to look at how one can predict induction mortality in intensively treated patients, and you can use this to decide between the treatment options which are available. Another factor that would play a role in deciding treatments is the chance of achieving a remission with these therapies. So for example, if you have adverse karyotype AML, the chance of achieving remission with the standard 7-3 is less. So one would potentially move towards low intensity therapies like azacitidine, venetoclax in such a scenario. So as we discussed, these are the standard options that are there in front of us in India. 7+3 midostaurin is available. You can add it if FLT3 is mutated. Azacitidine, venetoclax is the other extreme in unfit patients or in adverse risk AML. There are other factors also which would help us, like monocytic AML, better not give azacitidine, venetoclax because they are mostly MCL1 driven, so one would probably err on the side of giving intensive chemotherapy there. Gemtuzumab not available with us unfortunately, but if it was available, we would have added it for all favorable risk AML, because it results in 20.7% improvement in the 6-year overall survival, and only a single dose is enough. If you give 3 milligrams per meter square of Gemtuzumab with every cycle of chemotherapy, it improves outcomes. So it's an important point for us, all of us, to know. Now, going to venetoclax, that's always the debate. How much, what duration, how many days to give. This is data from Mayo Clinic looking at, venetoclax duration between 14, 21 and 28. Essentially no difference in toxicity. But I would like to point out certain aspects of data set here. Here, if you look at the ELN adverse risk category, when 14 days was 22% CR rate and when 21 is 60, the p-value is 0.07. So we need to be careful, everybody is cutting down the dose of venetoclax to 7 days, may not be appropriate in certain situations. I mean, although this is very early data. Now, 7.3 is probably very toxic, Azaven is on the other extreme. This is data from MD Anderson where, this is sort of the middle path where they've tried giving cladribine, low dose cytosine and venetoclax. Good response rates, almost 93% composite CR in this group, where they alternate the clad LDAC ven with azacitidine and venetoclax. Interesting, study, and probably, it's somewhere in between 7.3 and azaven. Now, the other question that is often asked is why not give flag in India. So I think there was a publication from a center from Delhi as well, looking at FLAG-1 versus 7.3. This trial tries to answer that question. This is the AML-19 trial. They had enrolled non-adverse risk AML and essentially compared 7.3 plus GO versus FLAG-IDA GO. No benefit, no overall survival difference between the two approaches. The cumulative incidence of relapse was higher with 7.3. But when they did a subgroup analysis for core binding factor leukemia, absolutely no difference. So I think still for core binding factor leukemia, the final word is 7.3 plus GO. It's not changed to FLAG-IDA. Now, I'm sure all of us are aware that monitoring with ddPCR or qPCR for NPM and CBF AML is recommended. If you don't have a 3 to 4 log reduction at the end of therapy, then these patients might benefit from a transplant. I'm not going into the details of this. This is the basis of that recommendation. Again, in non-intensively treated patients, venetoclax-based regimen, there is some data that one can de-escalate therapy if you are MRD negative at the end of 4 cycles of azacitidine venetoclax. Again, very important for clinicians to know. Now, selecting consolidation therapy, in Dr. Pranta's talk also, there was a discussion on the AI being used for deciding most of these things. I agree that this is a very complicated decision, because it depends on both the risk of relapse following chemotherapy vis-a-vis the non-relapse mortality which is associated with transplant. Generally, the rule of thumb is if the relapse risk without transplant is expected to be more than 35 to 40%, one would go for a transplant. And life is getting more complicated with all the NGS reports that we get. Now, the next step is the dose of cytosine that is used in consolidation. I'm sure that all of us are aware of this data from the AML-15 trial comparing cytosine 3 gram versus 1.5 gram showing no difference. But if you look at the supplementary data, this is the outcome is almost 60% relapse versus 51% between the two groups, and the p-value is 0.06. So one needs to be careful in reducing the HiDAC dose. If you look at the systematic review as well, the subgroup that seems to benefit from giving high dose cytosine is the favorable risk group. So one would be careful in cutting down the dose of high dose cytosine in that group. So better to give 2 gram at least in that group. Other groups probably one can come down to 1.5. In patients who are unfit to continue chemotherapy after they have achieved remission with intensive therapy and they are not fit enough to continue consolidation, oral azacitidine is an option, and this is accessible to us. Coming to post-transplant strategies to reduce relapse risk in high-risk AML, DLI is the standard, but again caution, should not give it in haploidentical transplant outside of a clinical trial. So if you are doing a high-risk AML transplant, match sibling or match unrelated donor transplant, taper the immunosuppression, start the donor lymphocyte infusion. That's the current standard in absence of GVHD, except for in situation of a haploidentical donor. What else can you do to prevent relapse? Again, the figure on the right is a failed trial on looking at azacitidine maintenance to see whether it improved relapse risk, and there was no benefit of azacitidine. There is criticism of that as well, and this is from a Chinese trial looking at giving GCSF and decitabine, and they have moved it towards the conditioning as well, showing some benefit in relapse risk reduction with the use of this strategy. In all FLT3 positive cases, we are offering sorafenib maintenance post-transplant, and that is based on the SORMAIN trial. One has to be careful about the cutaneous side effects of sorafenib when you use it. Lastly, coming to post-transplant relapse, again a very difficult scenario. There is some data on using azacitidine, lenalidomide and donor lymphocyte infusion, len at 5 mg, 21 days, and escalating doses of DLI. And we have preliminary experience with using this, and the data looks good, almost 50% responses even in patients who have hematologic relapse. So with that, I would like to end the discussion. Thank you. Happy to answer any questions.
Thank you, Dr. Uday Kulkarni. That was a lucid presentation. I have one question. You made a comment regarding germline testing. Yours is a very high volume center. So usually Li-Fraumeni syndrome, what is your treatment approach when they got diagnosed with leukemia? Will you de-intensify the dose, or there is a mixed data regarding the management of Li-Fraumeni?
So TP53 is a major problem. I don't think there is any answer. Whatever you do, whether you give intensive, no difference. Whether you transplant, don't transplant, there is no difference. Overall survival is in the range of median survival is 6 months. So that's a challenge, and I don't think there are. We would use azacitidine venetoclax for sure. In fact, we had last year we did one transplant for a patient. He's so far doing well. So it's not uniformly bad. If you get some good remission with azacitidine venetoclax, probably that's the best way forward. Yeah. And of course, because if you have germline testing which is positive, you need to test the donor as well. Yeah.
Most patients present with advanced disease, and treatment starting is very crucial. So if germline mutation as testing has to be done, it takes at least 2 weeks to come. Should we wait?
So I don't think germline testing is that important for the initial treatment selection, but in certain situations where we discuss, the ELN recommends doing germline testing, and that can happen parallelly when the patient is on therapy.
Any more questions from Dr. Uday Kulkarni, please? Okay. I think everyone is hungry, Mr. Uday. Thanks. Thank you so much for this excellent presentation.
Thank you.
So only one more talk between the lunch and us. So last but not least is the adult ALL by Dr. Sanjeevan Sharma. Dr. Sanjeevan Sharma is the Director of Army Medical Services, Ladakh.
Nee, but I can move from here also, no? So, good evening. Is it evening already? No, I think it's still afternoon. So, firstly, I'll begin with the customary thanking to Yashoda Hospitals, Dr. Ganesh for inviting me here to give a talk on this adult ALL in 2024, and I bring greetings from the land of the mighty Indus. For those of you who would not know that the only state in our country where the Indus flows is Ladakh. Rest all is now post-partition gone into Pakistan, and that's where we derive our name India from. So this is a view from my office. I clicked this picture about a couple of days ago before coming here, and this is what Ladakh looks like. And what Ganesh has done is he's absolutely now set a new benchmark for all hematology conferences, the kind of environment in which we have all had, it's looking like a PVR rather than anything else. So beautiful, and the way the entire conference has been conducted, the educational content, the the other content, everything is fantastic, the aesthetics and everything. What Ganesh has also managed to do is, if you wouldn't have noticed that in the last 1.5 days, we have covered 56 topics. So Ashwini Vaishnav needs to take a little bit of tips from Ganesh before he launches his bullet train, because that is what he's done. So in ALL, I'll not be giving any data, the kind of intricate data which Dr. Uday had given. I'd just like to share a few thoughts about adult ALL. And as the chairperson has very rightly mentioned, I'm standing between you and lunch. So let's not increase the hypoglycemia any further. Suffice it to say that the pediatric ALL, which we heard Dr. Revati Raj in the morning, the success story of pediatric ALL, which as low as 10% to 80% in 99 and now 94% cure rates, and almost around 90+% rates in APML have not been replicated in adult ALL. And this is the graph which was shown for pediatric ALL from a dismal prognosis so early on. Now we are looking at 90+% cure rates in ALL. But if you see our data on adult ALL, early mortality as well as the OS, all of them is all in the 30s and the 40s range. And the problem of poor prognosis in relapsed ALL is even further. If in case the disease relapse, the survival is as low as almost it is hugging the baseline, around 5 to 10%. So much so that way back in 93, people wondered, are they two different diseases? We just calling it acute lymphoblastic leukemia, but are adult and childhood ALL two different diseases? They of course had various factors to think of, whether clinical factors, biological factors or social factors, but nevertheless the differences are marked. So if you were to just address, say, let's say 5 important questions in the next few minutes, they say, what are these 5 questions which I would like to address? Can we risk stratify? Any chemotherapy modifications, role of MRD and special subsets, and are there any new targeted therapy? So risk stratification, conventionally have been been used to modify treatment, intensify treatments in certain subsets, and at the same time de-intensify treatment in the very favorable range. So that holds good even for adult ALL. And Dr. Ankita just had a beautiful overview of the NGS technology, and the current role of NGS, however, is coming in a big way in trying to further risk stratify. But any investigation in the world goes through 2 phases. First is the discovery phase and then is the clinical phase. So right now NGS is still going through a discovery phase. We are finding newer and newer targets, trying to identify, but we have still not been able to integrate into our clinical practice. In fact, it's not even recommended that every one of our cases of ALL or AML for that matter should undergo an NGS in any of the guidelines. But yes, it's a beautiful new technique. It has got a huge potential, and we have to identify the potential targeted therapy. Except this one paper in which this is that BFM protocol in children. They have integrated NGS in their algorithm of managing patients. So they do the conventional cytogenetics by RT-PCR and FISH, but after a little while they add the RNA sequencing, and then they sort out the patients with the PH-like ALLs or the JAK-STAT mutated ALLs so that they can add specific therapies. So this is just early days, but still NGS has got a long way to go. So chemotherapy, this is a standard chemotherapy which we give for any ALL. It goes through the induction, consolidation and the various phases. So one major change which we have done in ALL chemotherapy for adults is that for the adolescent and the young adults, that is for patients up to the age of say around 30 years, we have started giving them pediatric inspired protocol, or something what we would give to a 10-year-old child, we will give it to a 30-year-old person. And that has really pushed up the overall survival rates from as low as around 40% over 5 years to 80%. And of course, the reservation of using asparaginase has been taken away, and now we are using PEG asparaginase pretty more liberally, as long as we can take care of the toxicities. MRD, definitely in pediatrics now almost every protocol has included MRD as a way of deciding what to do next, because it has got its own benefits. Although its requirements are there, the sensitivity has to be 10 raised to -4. And as we can all see, it just like in pediatrics, even in an adult patient, it does predict early relapse or a late relapse. So MRD needs to be integrated, whether we are using the conventional flow cytometry based MRD or the less frequently used PCR based MRD, or as Dr. Ankita mentioned, even NGS is coming in a big way in MRD assessment. Whatever tools we do have at our disposal, MRD should definitely be included in adult ALL. And this is a paper which very clearly amplified, even they divided their ALL patients into the ones who did undergo transplant or not. MRD negative people, even with no stem cell transplant, had the best prognosis as compared to the other groups. Special subsets, early T precursor for adults is extremely poor prognosis. As we can see, whatever therapy we may use, whether we use nilarabine or chemotherapy alone, it's got a poor prognosis. Same is, but the things are slightly rosier for the pH-like ALLs, because we got almost around between 12% in kids, but around almost 20-25% adults. So we should try and identify the pH-like ALLs, because the mutation profile is different at different age groups. The best part is that we've got a whole host of therapies or targeted agents which we can add on if we can identify our patients of ALL with pH-like, because if we do not identify, then they are the ones who will ultimately relapse and have a poor disease. Same thing goes for patients above 65 years of age. We have to take their comorbidities into consideration, and this is an algorithm which says that, you know, every elderly has to be decided whether it's an older fit or an older unfit, and then proceed. TLL, one single slide on TLL. Why? Because it's the frontline therapy which is going to matter. Any relapse in TALL, it's almost doomsday. The prognosis in any relapse TLL, then whether we use a transplant or anything else, of course there are no CAR-Ts available for TLL. So whatever we have to do upfront. So whether we use chemotherapy or chemotherapy with immunotherapies or combined with HSCT, but it has to be upfront. Lastly, coming to newer immunotherapies, now we are in an age where we've got a whole lot of new drugs coming up, and inotuzumab, blinatumomab are the new kids on the block. Inotuzumab, as you know, it's a drug antibody complex. So this antibody binds onto the CD22 and inserts this very toxic drug directly into the tumor cell, and that's how it ensures tumor kill. At the same time, blinatumomab is a bispecific. It binds to CD3 on the T cell on one side and to the target CD19 positive leukemic cell on the one side. And the moment the two come in close conjunction, the T cells proliferate, they get activated, and then they go on and destroy the leukemic CD19 positive cells. So there have been these studies on novel agents approved as for B cell ALL. Initially, all of them have been tried in the relapsed refractory setting. Blinatumomab, of course, has been even for MRD positive individuals of ALL, B cell ALL, where we would like to take up for transplant, and if the person continues to be MRD positive, we can give a few cycles of blinatumomab, get them into MRD negativity and use them. So as of now, blinatumomab is being used as a bridge to transplant. But what is coming up is a combination of novel agents we can use both inotuzumab and blinatumomab rather than using them individually, combining them with the venetoclax. So the future for adult ALL is pretty, I would say, hopeful, if not rosy. As of now, adult ALLs, when we look at, and as hematologists, we feel that we are dealing with a disease which very little future ahead, but probably in times to come, it's going to be different. And again, certain trials in ALL are mentioning about using these newer agents, inotuzumab or blinatumomab upfront, especially in the elderly, where we want to avoid a chemotherapy. Say, what do you do to a ALL above 65 years of age or so? So what, when and azacitidine have done to AML, probably we are going to see inotuzumab and blinatumomab doing the same thing to ALL. So this is one more study from on the frontline inotuzumab. So the studies on blinatumomab, and this is a very good paper which said that is it a curtain call for conventional chemotherapy in older adults? And I do believe with the author that yes, probably in 5 years from now, when you diagnose adult ALL, you will probably not burden him with the toxicities of chemotherapy, as long as the availability of these novel agents will become more and more, and probably we will get them at a much more affordable rates. Probably we can spare our adults of the risk of a toxic chemotherapy. So I end my talk here with a thank to Dr. Ganesh once again, and I'll be happy to take on any questions, more likely on the email form rather than physical forms, because as the chairperson said, probably we are getting too much behind schedule. Thank you very much.
Thank you, sir, for this lucid presentation. And I hand over to organizers for vote of thanks.
I thank Dr. Ganesh for giving us the opportunity to chair the last session. We are, Ganesh and we together, along with Telangana Oncology Group, we will be hosting Indian Cancer Congress 3.5 years from now. So I request all of you to please join us and make this biggest cancer congress for the first time we'll be doing it in Telangana to be successful, like how we have done this Hematocon successful. Thank you.
Essentials of hematology to the most advanced developments of hematology, and I'm really, it's heartening to see 50 plus attendees, delegates, faculties still sticking to the screen at 2:10, where actually the conference is 1 hour behind schedule. And what is special about today is advances of hematology on the context of World Cancer Day. I just 50 seconds video because none of our esteemed speakers has.
Hello everyone. Every day we are making phenomenal breakthroughs in understanding and treating the cancer. On this World Cancer Day, let us celebrate the progress we have made and let us look forward to a future where cancer is no longer a life-threatening illness. Remember, cancer doesn't discriminate, and neither should be our efforts to provide the care and support. On this World Cancer Day, let us pledge to close the care gap and provide everyone, irrespective of their background, the access to best possible cancer care for its complete eradication from the mankind. Thank you.
That was the theme, close the care gap. This is the theme of this year's World Cancer Day. And before we conclude this August gathering and this fantastic Deccan Hematolink 2024, I would like to announce the last, the surprise winner of yesterday's quizzes. So I would like to invite Dr. Vaidyam Gautam sir. Is he here? So for being the winner of the contestant yesterday's quizzes. Thank you so much. And again, I like to thank on behalf of Yashoda Group of Hospitals, High Tech City, our organizing team, I'm the working face of the entire collective teamwork effort, our digital team, guest relations, our marketing team, Mr. Keyur and his Keeson's team. Everybody has contributed their more than 100% to make this conference a wonderful experience, not just a learning exercise. So with that, I would like to conclude this conference, and I'll look forward to have all of you again in another, even more and more numbers next year's Deccan Hematolink. Thank you one and all. Let's join for the concluding lunch.
इधर खड़ा होना है ना स्टेज पे, हम लोग को तो स्टेज से निकाल दिया ना टाइमर देख के अभी खड़ा हो यार.
Thank you, sir.
सबको बुला लो.
श्याम सर, डॉक्टर कृपा, आशुतोष, सदा,
मैं